last week.
Oh,
But I just wanted to listen in more on how they've been working on it so far. The website that they were using, I don't think it's necessary to use it, but I think since they're the ones who are leading it, they should just go with whatever is comfortable. But yeah, I'll listen in and see if I can give any comments.
okay. So we'll get to that part, but I'll hear from undergrads first. Grace, any updates?
I also don't have much updates. I am going to, I know I say this every week, but I'm going to get the variant classification project up and going again. And I've been working on setting a timeline for myself so I get that done before graduation. And I'll be reaching out to like the other people involved in this so we could pick this up again. But one question that I had is, are we just sticking with the same gene list that we had for the abstract, just looking at more variants, or also adding more genes?
No, I think the variants are fine. We're just adding all the relevant variants, not limit to 10.
Okay. And yeah, then otherwise that's all it for me, and I'll reach out to everyone else soon.
Great, thank you. Eileen, do you have any updates?
Mr. Albert Curie's video has been completed, and I put it as unlisted on the YouTube channel, and I was waiting for the thumbnails, and then Shauna sent them to me this morning, so I could actually show you and I'll give Shauna feedback on like whatever edits we might want to make. So
Yeah,
I can
can you, well, I actually watched the video. It's really good. And once you add the thumbnail, actually you can post it on the actual our website and YouTube. Yeah. And then maybe to make it more searchable, I think the title was Meet.
Yeah, I was gonna ask you for suggestions on that as well.
Let's see the thumbnail first. Let's see what, can you share your screen?
Yeah.
So I guess Richard doesn't know. We have this pacemakers movement where we try to interview healthcare providers and patients and really focus on doctor-patient relationship and how best to support patients and their caregivers. Okay, so these are two options.
So I think Shauna said first double lung transplant, but isn't it like at Northwestern is the first one, not in general? I wasn't sure. Maybe not.
So take out the first because we did the first double lung for COVID patients. And for cancer, I'm not sure. Eugene, oh, you and maybe Minjung, you searched literature, and I know cancer patient had transplant before.
Yeah, a few case series is already reported on that, and it's also already in the like indication as well. Although the number is small, yeah.
So it's only the non-sequential, it's the first, right?
Yeah.
The double lung has been done in cancer patients.
True,
so
true.
I think we should take out the first, and it says double lung transplant for lung cancer patient, something like that. We double lung
It'd be
transplant.
weird.
Huh?
How about if we did meet double lung transplant patient Albert Curie? So change first with meet.
Yeah, meat fine. Yeah, meat is fine.
Okay. And then the title of the video, could we also do that? Meet double lung transplant or something like that along those lines.
I think we should also stress the fact that he has cancer, because so what's the best wording then? Meet double lung transplant patient.
Maybe we could say meet double lung transplant patient who had cancer.
patient and cancer survivor. Mm,
Meet double lung transplant patient. Oh, and then maybe at the bottom, another banner says cancer survivor or something. Oh, lung cancer survivor. That's better. Yeah, maybe do a change first to meet and then have the same banner and just put lung cancer survivor. I think that will, and so that should be the title too. Meet double lung transplant patient Albert Curie, comma lung cancer survivor or something. Yeah, and then Northwestern or. That makes sense, Eileen? Any other suggestion from the group?
That would be fine. The two banners.
Yeah, looks good. Looks good.
thank you.
Thank you. Yeah, I watched the video yesterday. It was really good. So thank you. And then for the captions were good too. So all right. Anything else, Eileen?
Nope, that's it.
Okay. So just work with Grace to launch get the variant classification running. And let us know your deadlines and what the plan is. And did we decide on the journal, Grace?
No.
Maybe we can write it very short and maybe do JCOPO. JCOPO. And if that doesn't work, we can. The next one can be. MCT, Journal on Molecular Cancer Therapeutics. And then if that doesn't work, we can go to clinical. No, it's not just lung cancer. So if that doesn't work, I think there was a journal called Precision Medicine or something. I can't recall it. We can do the oncologist as a third option. So okay, just write it down somewhere that.
Yeah, got it. Thank you.
All right, very good. So we'll go to Janera.
Wait, Dr. Che, may I make one suggestion for the
Yeah.
title?
Yeah.
Instead of double lung transplant patient, can we, I think maybe it'd be better to write recipient
Because
because it's
I
not,
like that.
not a transplant patient necessarily. I know it's like really nitty gritty, but.
No, I like
And
recipient, better word.
one more suggestion I had was Penn Medicine also highlights some of their patients. And the way they title it is they first start with the patient's diagnosis and the treatment that they received. And then to make it more personal, they say, so for example, they say double lung transplant and cystic fibrosis, Kathy's story. And so I think adding story kind of makes it more personal. And also if we follow their format, then we can do mucinous adenocarcinoma and double lung transplant, which captures, I think, the important parts. So maybe on the top, you can do mucinous adenocarcinoma lung and double lung transplant, and then Albert's story or some maybe that might be a better way to summarize. But it's just a suggestion. I'm just looking at other videos.
That way we can follow
I
them.
really like that as well.
Eileen, what did you say?
I like that idea.
Yeah, yeah. But Eileen, remind me, in the interview, he didn't say anything about mucinous, right? He didn't go deep into it.
Oh, he did say like lung cancer, but I'm not aware of like the full
Mm, mm. I think a lot of people would not know what mucinous is, and I think the focus is not on going deep in academics. Um,
So maybe just lung cancer and
Yeah,
double
maybe.
lung transplant.
lung cancer, double lung transplant recipient, and then Albert's story.
Would we still call it lung cancer recipient though? Or yeah.
So, Minjung, can you summarize one more time where, what?
May I share the screen really
Yeah.
quickly?
Maybe unshare Janera.
So I'm unable to share.
Janera, can you?
Oh, yeah, I think. Okay, all set. So this, for example,
Mhm,
here, double lung transplant and cystic fibrosis, Kathy story.
mm,
And there's one more, pulmonary fibrosis and double lung transplant, Andy story.
mm.
So if we go exactly with their format, then it would be lung cancer and double lung transplant, and then Albert's story. If we go with what we already have, then we can add double lung transplant recipient and something, and then, yeah, follow the rest of the format.
Yeah, I like it because right now here is well, I guess it's longer. Double lung cancer recipient and cancer survivor. That kind of describes Albert. So that's Albert's story.
Mhm.
Yeah. So I like recipient still. So lung cancer, double lung transplant recipient and cancer survivor.
Mhm.
I like last name too because it's unique about that individual. So Albert Curie's story. Let's do that. Eileen.
I'll try typing it out, and can someone confirm?
And yeah, Liam and Eugene make the SOP for all future that will help, like thyroid cancer, uh, and experimental therapeutics, or I don't know, immunotherapy and targeted therapy. That's too granular for lay person. So for like Vivian Panu, we could say thyroid cancer on experimental therapy or something, and then Vivian Panut's story or yeah, no, it's good. Eileen, yeah, I
Do
think
we want to put story at the end, or
yeah, I
oh,
like the story at the end. So maybe you can do 2 lines of one banner and the Albert Curie story at the bottom. 2 banner, yeah. No, I like it. Thank you for your suggestion, Minjao. Yeah,
thank
then
you.
we'll follow that thumbnail and also in the YouTube title, so searchable title. And once you post that in the YouTube as well as in our website, Eileen, can you post that into our lab messenger group chat so that we know it's there? And I will sort of spread it to people who are interested. Yeah. Thank you. All right. So Grace and Eileen, next week I want to see some progress on the variant classification and kind of give us update where you are. Okay, yeah, Junaira, we'll go back to you. Is yours your last week already, right? Is Friday your last day? You're muted.
Sorry. So my last day is on Monday, but I will join next Tuesday's meeting from Zoom from my hospital.
Oh, good, good. Thank you.
So we are finished with extracting 307 patients, and we have rechecked all data. So initially, like we checked that initially there was those mistakes, they were all corrected. We used the correct calculator, and now all data is checked and all data is extracted. From today, we will start calculating that how many the incidence of progressive disease through different using different because 3 different studies have used 3 different criteria. So we'll start calculating them, and also we'll make a table where we will show that how many patients were included and how many were excluded, because some of the patients were excluded because either they did not have the follow-up CT, or like some in the end there were few patients who didn't even receive immunotherapy. So we'll just calculate that the patients who received immunotherapy, out of which how many we excluded because of no follow-up CT, and then how many we included, and how many had progressive disease and how many had stable disease. So we'll calculate the incidence of progressive and stable disease, and then we will start writing. I think we, as like I'm doing the calculations, my other team members will start writing about the paper, the introduction of hyperprogression in immunotherapy. And yeah, that's the progress for now that we have finished data collection.
Okay, can you maybe pick a case and show the group what you did?
Sure.
Yeah.
So
Pick a random case.
okay, so I'm using 57. It's a random case. So what we did was like we checked the pre-baseline CT. Pre-baseline CT was the CT that was done 2 weeks or a month before starting the immunotherapy. For example, this patient before starting immunotherapy on May 19, 2017 had a CT that showed right apical mass, which was our target lesion of 54, and left lower lobe mass, which was also a target lesion of 43. Immunotherapy was started, baseline CT was done at immunotherapy or after 2 to 1 month of immunotherapy. So right apical mass has decreased to 51 and left lower lobe has decreased to 26. Then we have taken another CT that was our criteria was that we'll be doing after treatment CT, that is like 3 months after starting immunotherapy. So this patient got the CT scan September 6, 2017. Right apical mass has further decreased to 43 and left lower lobe mass has slightly increased to 37. But when we calculated the tumor burden, it was 77 and tumor burden percent change was only 3.7. So it's a stable disease. So the patient did like the tumor did grow a little in the last one, but in total the growth was not greater than 20%. So it was a stable disease and there were no new lesions or the other non-target lesions were stable.
So do you have tumor burden baseline and after tumor burden at 3 different points?
So for calculating tumor burden, we use the values and then it gives after immunotherapy.
Right. But to calculate hyperprogression, you need 3 points. Do you have tumor burden for 3 different points?
No, we just have it after immunotherapy.
So show me the pre-treatment one.
This one?
Mhm. So my suggestion is still to calculate the hyperprogression incident. You need a column after pre-baseline, tumor burden, which is RECIST score. After the baseline tab, you need to have another tumor burden, and after treatment tab, you already have tumor burden. So you need a 3 columns of tumor burden at time point 1, 2, 3.
Okay,
Okay.
so it will be tumor burden, not the tumor burden percentage, right?
Right.
So yeah, that we can do. For calculating that, we'll just have to add the values.
Right. I just want you to have them as a column so that we know.
Sure, I will add them.
Yeah. Okay. So how many eligible patients are there after you looked at all of them?
I haven't calculated all of them yet, but I think it's around, after we exclude the ones without CT, it's around 200 to 230,
So how many did you look total?
307, 307.
307, and you were expecting a little over 200?
Yes.
Hmm.
So we have written the reasons why we are excluding them. So when I'll be making the chart, like a Prisma flow diagram, so I will mention that how many were excluded for what reasons.
Hmm. So when you say follow-up CT not available, does that mean they received treatment that they never had CT afterwards?
So yes, some of them were like that they had the immunotherapy, but they did not have the CT that was within 3-month period. So our criteria was like after treatment within maximum 3 to 4 months of period, but they have CT, either it was done very late or the patient did not follow up, or some patients were excluded because they did not have on treatment CT. Like they had a pre-baseline and then they have after treatment, but they did not have on treatment. So they were also excluded.
So how do you define on treatment after treatment?
So on treatment is the any CT that was within 2 to 1 month of getting treatment. And after 3 months was after treatment CT.
So let's say you get treated you have 1 dose of immunotherapy.
Mm-hmm.
Maybe that person develops really bad side effect and was not, let's say, hepatitis, did not get any further treatment, but gets scanned, let's say 3 months after.
Mm-hmm.
Would this person qualify for this study?
No,
And why is that?
because the patient only received 1 immunotherapy and the patient did not continue the therapy.
Hmm.
So we cannot say that the progressive disease was due to immunotherapy failure.
Mm. So our definition is, I guess, so here's the thing. If a person gets nivo-ipi, Sometimes they get scanned 6 weeks later, or even 8 weeks later. And for logistic reason or side effect concerns, it doesn't get continued. But still, the immunotherapy can have effect. Some drugs last very long. So the reasonable clinical thought is you should still keep that patient.
Oh, okay.
Unless they switch to chemotherapy, like docetaxel, then you're not sure if the scan's done on docetaxel like a couple of weeks afterwards, then you're not sure if you're measuring docetaxel chemo response or immunotherapy response. So that's exception. Right? Even if the patient receives one dose, did not receive any further therapy, and it's still within 3 to 4 months out from the day one of treatment, you should include them. So you can have very deep and durable response even with one dose of immunotherapy. That's how powerful immunotherapy can be. Okay. We often think like, oh, you need to have at least 2 months of therapy to say that you've received a good dose of therapy to be evaluated. No, it's not that way. A 10 centimeter mass right at the chest wall can disappear with one dose.
Wow.
10 centimeter, leaving a hole in the chest wall. That was the NEJM paper published a few years ago. It could be like one-time vaccine. Very deep response, very durable. It's not always that way, but it's possible. And you know what? People who experience side effect from immunotherapy are the ones who are most likely to have very good response, even one dose. We know that's the predictor of good response, having immunotherapy side effect. And those are the ones who gets the least amount of dose because of side effect. But they're the ones who's going to live the longest because your immune system is boosted enough. So this is such an interesting story. That's why immunotherapy is so unique, unlike chemo or targeted therapy. Okay, so you need to, in your method, show exact criteria what you use to select patients.
Sure. So I will write the method section so that I can show it in the next meeting.
So first scan within, let's be generous, 4 months.
Okay.
Has to be on immunotherapy. If they never received it, they at least have to receive it one dose. If they change therapy, well, let's say they changed to chemo and got scanned a week after the new chemo, second line chemo, you should still count that because 1 week is not going to make much difference from the chemo. So this is all clinical reasoning. I would say you can say completion of immunotherapy not by the regular interval. Let's say that if the chemo is second line treatment is resumed or it started, then that would be the completion day of immunotherapy. And you would say the CT scan should be done within 2 weeks of the completion of immunotherapy. The completion day is defined by the start of the second line therapy. Okay? Because it's like a 2 week is too much for the chemo to show effect.
Okay.
It can, but still you can argue that 2 weeks it reflects what happened with the immunotherapy. If it is still the first scan, that was ever done. So just
Mhm.
put those rules in place where you find the right patient. But most people are going to be immunotherapy 2-3 dose, and you get the scan 6 to 8 weeks, 6 to 9 weeks. So I think that's the majority of your patients.
Yes.
Now the second issue is someone who just received targeted therapy or chemotherapy alone without immunotherapy. I would like to know their number. If they are like maybe 50 to close to 100 patients, I don't know. If it's sizable number, let's say more than 30, I think you should put them as a control, calculate hyperprogression rate in that group. Just use that as a control. Maybe hyperprogression is 0. Maybe there's one more. I'll see you, Richard. It's recorded, and we always put that. So, yeah. So I think you should still calculate them as a control. As long as you have 3 different time point tumor burden, you can still calculate.
Okay, sure.
Okay. All right,
Thank
go
you.
on. So what is your plan, and what's next?
So plan is to calculate, to make a Prisma diagram that how many patients we have selected that's following our criteria, how many we have excluded, and for what reasons we have excluded, and then to calculate the incidence of hyperprogression. And as you mentioned now, that for control group, if they are greater than 30 patients who did not receive immunotherapy, we can keep them as control and we'll calculate hyperprogression in them.
So did you talk with Minjung about which method you're going to use?
No, I have to set a meeting.
Okay, so Minjung, can you go over just one more time the options of different definition? I just want to use this time to remind ourselves the different definitions. Can you share maybe your prior?
Oh, right now.
Yeah.
Dr. Chae, should I just, I don't know how much details I should
Oh
provide.
yeah. So maybe what the different definitions are and how to calculate them very, very briefly. I just want to
Okay.
orient people.
Mhm. I'll share my screen. So I think this might be helpful at this point. Since Dr. Zanera and Arnie have an idea of the time points and what to measure. So the important part in defining hyperprogression is the change in the size within a certain time duration. So when you look at this timeline here, you have 3 time points: pre-baseline, baseline, and post-baseline. And we can just use the letter D for diameter for size. So what RESIST is doing, or the other radiological evaluations, is it simply looks at the change in the sizes between time points. So size at time point 2 divided by size at time point 1. If that change is greater than 20%, then we call it progression, or if there's presence of new lesions. And now hyperprogression is taking into account the time. And so when you do that, you can get the tumor growth kinetics or the tumor growth rate. It's the same thing, but they're just using different terms. It's just mathematically different. So what Dr. Arnie and Dr. Zanera have done are these first two parts. And now they have to calculate the tumor growth kinetics. Let's see. I don't think I should do the math.
Oh, the definition, yeah.
Mhm. So as I mentioned, if you look at progression, or if you look at resist, that's only taking into account the change in the size without regarding the time. Hyperprogression, you have to consider both the resist evaluation as well as the change in the growth kinetics. So these are what they consider the main 5 definitions of HPD that are most commonly used in the literature. The first, no, never mind. Yeah, and the definitions that I recommended during our Zoom meeting were the first one, the third one, and the 5th one. And just looking at it really briefly, you notice that for this definition and this definition, you take progression into account. But then Sadabuzir et al. Doesn't do that. They think that if you have this ratio greater than equal to 2, then you automatically should have progression, but it's not always the case.
Right.
That's why this is not the most reliable per se definition. And in order to improve on this definition, nowadays people are adding the criteria of resist progression into this definition. But yeah, it's still commonly used because it's mathematically easy to calculate. All you're doing is taking the resist numbers and then dividing it by the time. Whereas the first one and the last one is using a model of exponential growth, and they kind of change the terms to represent the volume. So Champia and Ferrara both use a tumor growth kinetics term called TGR, tumor growth ratio. The difference between the first one and the last one is that the first one takes a ratio, and then the second one takes an absolute difference of the growth rate. So I think these 3 definitions are the ones that we should use. Nowadays, a lot of papers are comparing multiple definitions, and these 3 are almost always included. So I think, yeah, if
No, I agree.
we were to choose.
Yeah, I agree. We should choose 3. And I suggest now we have volumetric for all 3 time points.
Volumetrics?
Yeah.
Yeah,
So
we-
volume was calculated, the tumor volume. Dr. Yuri did it. So Eugene O has that data. So Eugene O, make sure Arnie and Janera uses that to calculate the volume-based definition, which is not listed here, right?
Got
So
it.
is that the one that Samsung Medical Center used? Minjung?
Yes, they use the volumetrics based approach.
Yeah, do you have that reference?
Oh, the paper?
Yeah, because that's not in this JAMA oncology paper, right?
It's not.
Yeah.
And they call it HPD with a subscript V. It's this paper here.
Written by Eugene.
Yeah. Let's see. They did 2 approaches.
Oh.
One, they tried to go with the traditional method, but it's actually kind of not. They kind of still twisted it, so it's not. We couldn't include it in our analysis. But
I see. But show us the volumetric description.
It's pretty much the same, but it's here. Similarly, after baseline, TGK was defined as, so they just take the volume differences and divide it by time.
Okay, so very simple. They just use volume in place of the resistum.
Mhm.
Okay, so this is number 4. Okay, Janera and Arnie,
Yes.
we're gonna use 4 different definitions. 3 in the JAMA oncology paper, and the last one is this paper using the volumetrics. So I am not sure if everyone will have volumetrics. So because it's not resist based, did they use resist progression here or not? You
They
know,
did.
they
They
did?
did.
Okay. So what I'm saying is the 3 groups will share all same patient, but the volumetric group, it depends on whether Dr. Yuri in our radiology department ran volumetrics or not. So make sure you know the overlap and no overlap between those 3 and 3 definition and the first definition group, 4th definition group. So next couple of days, make sure you calculate hyperprogression incidence according to this method. And then that should be, so let's see. So I think, so Yunho submitted his hyperprogression data to what meeting? Minjung, do you know? Eugene?
I believe it was, oh wait, Dr. Yushin.
I believe it's ASCO,
ASCO?
but I will double check with you.
Okay, so I think at AACR, presented the abstract, and then Hyunsun was the first author, right? AACR.
AACR.
You
For
mean Dr. Horian?
No, Dr. Hyunsun.
Is it this one? Or it's not?
That's-
Oh, no, it's not.
That's the case report. So maybe ask Dr. where,
where he submitted the abstract.
yeah, I think he submitted to
It's
ask.
AACR.
Is it AACR? Yeah, I might be wrong.
So we presented the incidents first in AACR, I think.
Mm.
Do you have that manuscript abstract, Minjung?
Mhm.
Can you share this?
Yep, I think it's this one. Is
Yeah.
it this one?
This is the one what I saw.
Hmm.
So this is Hyunsun and Yuno submitted this. And this talks about our incidents and the risk factors associated. And this was ACR. And then we added few more patients. And then we looked at Veristrat as a hyperprogression predictor. I don't think we have Veristrat here. Do we? I don't see it. So submitted that for ASCO. And I don't know if he got it accepted. I think he did. Maybe as an e-poster only. So Eugene will follow up to see where we are.
Okay.
And we have the next, so we submitted, I think we had World Lung, and then we have the next one is Sissy. That's coming in November.
Mm-hmm.
So Arnie and Janera, you guys can shoot for Sissy meeting, which is going to be in Boston this year.
Okay.
So our Northwestern experience in terms of evaluating hyperprogression incidents and maybe some predictors with, I think we added more patients. So like with, and then the volume at 4 different definitions. So when we do this analysis, we will write abstract for the SITC meeting, okay, SITC.
Okay, Doc, thank you.
Yeah, so Janera, that's my expectation. At least finish the abstract, okay?
Yes. No, I will work on the full length also. I have one question from Minjong Kim.
Yes.
If we can please set a meeting later, and if you can just teach us on one patient how to calculate the progression so that we can do it for the others.
Mhm.
Okay.
Yep. Let's do
Whenever it's feasible, you can text me the time or email me the time. Okay. Thank you so much.
Thank you.
So yeah, let's do the abstract. And then everything combined, this AACR, ASCO, and the SISI, we're gonna merge that into a one big paper. Okay. And that paper, Minjung, I still want you to be part of the co-author because you're kind of teaching them. And I don't know, will be during his residency soon. So I don't think he will be available to finish the whole manuscript. Arnie will still, work with you. Shunera, I don't know how available you will be since you will be, working in the hospital, but it's up to you. You could be like Dr. Issa Kim, who still works with me while doing intern. So it's up to you. We're always open to people who wants to work. What I don't like is you commit and you don't show up to the lab meeting, or you don't give us update, and you say you'll do it, and there's no updates for the next few weeks, and that's where things get awkward. Like you occupy the space and you're saying you're busy and nothing gets done. So we don't like that. So at least if you want to carry on, you have to say, this is the bandwidth, this is going to be my commitment, and I will stick to my commitment. And I don't see that happening for other lab members. So I want you to be cognizant of what you can and do, and I will be supportive. Okay?
Yes.
Okay.
Thank you.
But at least while you're here, let's finish the abstract for the SISI. You read the SISI guideline, but the point is, for the first time, we are reporting incidents based on the 4 different definitions. That's the whole idea in the real world.
Thank you.
And then you can do some, basic correlations that you did with the AACR and ASCO predictors, and how that correlation changes by different definition. So you can do a lot of different analysis.
Sure. Thank you.
Any other comments, Minjung, on this project?
I wanted to make 2 comments, I think. One was for the first evaluation post immunotherapy. Was it 4 months that you set as the maximum time?
Oh, to have like the last scan?
Mhm.
Yeah.
Did, by that, do you mean from the time you start immunotherapy to the first scan?
Mhm.
So usually, I think the longest that I've seen was 3 months.
Mm.
And generally they use 6 to 8 weeks
6 to 8.
because that's the RESIST recommendation for the first evaluation after starting immunotherapy. So that's the general pattern that.
Yeah. I mean, in real world, because of side effects, sometimes we stop treatment and get scans whenever they get better. So, I think we lose patient by being more strict. But I guess we also have to be mindful that we have to be in kind of line with the other literature.
Right.
In that regard,
So I think maybe 3 months at max.
Yeah,
I think it's because they, oh, sorry.
yeah, no, I think 3 months is reasonable. Let's make that 3 months.
Yes, we use the 3 months criteria. So I think 3 months.
Yeah, 3 months is okay. But again, the number of cycles received doesn't matter. So that's the difference. Okay.
The second point was the table that Dr. Zanera shared. When you were doing the response evaluations, the tumor sizes that you were looking at, which 2 time points were you using? Because it seemed like you were using baseline and pre-baseline, at least from.
For using baseline and after treatment.
Oh, okay. Then that was my misunderstanding. And then the last point was for the tumor kinetics calculations. Let's see. I think, well, actually this I can just message you after the meeting. So yeah, that's it.
Janera, maybe you can share your Excel file with Minjung so she can kind of briefly go over it.
Yes, I'll share it now.
Yeah.
Okay. That's all for me.
Thank you, Minjung.
Thank you.
Yeah. How's it going with your other studies?
Just slowly working through.
So you're becoming expert in pharmacology, anatomy.
No.
Good. But thank you for coming and always helping out. And I think yeah, so what you have reviewed is going to now be explored in real life data. So I think it's really good. And see, the next level, Minjung, Janera, and Arnie is going to be, we have all these radiomics AI features, which are now scored and analyzed in different ways. So the next question is there a radiomics AI feature, okay, that will predict hyperprogression? And what definition can do the best job in terms of kind of, showing that correlation? So we can ask a lot of these questions that no other group have asked. Minjung, did you see any radiomics paper predicting
There
progression?
were 3.
And what was their performance? Was it good or?
I think it was pretty reliable in one paper, but the other 2, they said they were still modifying it for future use.
So because and then they were probably just radiology group or radiomics only, or did they combine it with other clinical factors?
I think
Maybe there was.
I think it was just radiomics for one, but then the others also looked at clinical factors.
Mm. So maybe it's good to do what, see what other groups have done, and we could do our own thing, kind of realizing what more can we do. So can I ask you a favor? Can you forward me and Eugene O, Arnie and Junera, and then well, Eugene O can forward to both of them those 3 papers, radiomics and hyperprogression. So we can read it, and then I'll also share it with our radiomics uh, professor so that he's also updated on what's going on in the field.
Mhm.
Yeah.
The thing with the papers that use radiomics though is that it was only the Samsung paper that used the volumetric definition of HPD. The rest of them went with the resist criteria.
Oh, okay.
And there was one more thing that I wanted to quickly mention. When we're taking the volumetrics approach, instead of taking a 20% increase in, well, actually, never mind. I'll think about it. I need to think about it. But
Okay.
I'll message Dr. Zanera. And yeah, it
20% may not be the best cutoff. Is that what you're saying?
right. I mean, if we have the volume, then a 20% increase in volume in 2 dimensions is equivalent to around a 50% to 60% increase in the volume.
Right. So how did Samsung Group solve that dilemma?
So they added the additional criterion of minimum 50% increase in volume in addition to, I think, progressive disease.
Yeah. So
think that-
just be consistent. Let's use whatever they used.
Yeah, I'll look at the papers again.
Yeah. So it's not 2 dimensions, 1 dimension. It's 20%.
Right. I mean, yeah, right.
But I think that will be the future. I think the computer will calculate the tumor. Just like Lunit counts the lymphocyte, computer will do everything with a better algorithm, and it will be much better. But we're just still very primitive, and that's why we have work to do.
Yeah.
All right.
And
Thank you so much.
thank you. And thank you, Dr. Anya and Dr. Zanera, for all of your hard work. I know it takes a lot of time to do all
We
of the
are
data collection.
We are the ones who said thank you.
Tell me what.
Mm,
I know Junera told us, but do you have anything to add?
No, she's really good. I mean, like we're working together, but I think for talking, like she's better for explaining than me. So yeah, but it's the same for all she talked before.
Good. So
Thank you, doctor.
Thank you. As you finalize patients, I definitely want, like I said last week, double check. I don't want there to be any error. So anything you did has to be checked by Genera, vice versa. But it's good that we can, because we have the raw data. Because Minjung, what I found out was I thought radiomics groups will do resist, because I know Hyunsun has done it. That's the only way she said there's hyperprogression, right? But she didn't leave a raw data. So what we did is, and then I thought Yuri or somebody in the group will do the resist, and I found out they have no plans to do it again. So that then there's never going to be 2 people, cross-checking, which is super important in this type of task. That's why it's a blessing to have Junera and Arnie working together at this time to make it happen, cross-check each other. So thank you again for your hard work. And it's the fun time. Fun time is analysis time. But understanding the science, the mathematics behind it, all that is super fun. And then kind of see in the real world what comes out from it, and what are the new associations we discover. And what we do can really make, a impact in the real world setting. See, if we make a strong argument, well, this is the best definition, or this correlates best with the volume, this, because no one has really compared like a volumetric with the other definitions in the real world. Minjung, right?
The Samsung paper did try to compare, but it wasn't the way it's traditionally done. So I would say it's technically the first.
Right. So we can make that argument. Although I do think a volumetric should be the gold standard in the future, but see, RESIST is very primitive way, but every clinical trial still uses it. So we got to find, middle ground and make a strong argument that this should be the most reasonable way to assess. And the more and more tumors are being treated with immunotherapy, so people will look to the ways to define hyperprogression, and they'll always reference the one that is most comprehensive review, and you'll quickly realize everything you do publish will have impact. So all right, next we'll go to Seungmi.
Hello. So yeah, so I think I spoke with you, Dr. Che, yesterday briefly about how I think there was a misunderstanding on my part on the kind of what progressive patients are, and the timing of their signature has to be before the recurrence. And it looks like some of the patients who were progressive had signature done at the time of discovering the recurrence or even after, and that will decrease our number of progressive patients from 7 to a lower, which is what we use in the abstract. Hello? Oh.
Oh, I can hear you.
Okay. Yeah. So do you think we should go through? So Judy helped me a lot with the writing when I gave her like a very small amount thing to work on with the introduction, but then we both came to a conclusion where I think we need to have the results sorted out before we focus on how to write the introduction. So do you think we should go through patients one by one?
So we're making revision to the patient eligibility.
Yes.
And I answered a few of your questions. So in order to confirm the eligibility of each patient, do you need for me to review some patients? Or
Yeah. Yeah, together. So should I just present one, for example, and then it kind of gives you an idea of what the other cases are like?
or
Let's see. So with, let's see, sorry. Larry D. Smith, he was stage 1B and he got surgical resection, and then he was stage 3, and then within 2 weeks, stage 4. And his first signature was taken at the time he would be stage 4, because that was his inpatient visit. And so that would make his first signature result, that would make him not eligible for a test, for our study.
oh. So stage 3 must be just during the workup. Is that?
Yes, because I think he had a 4R lymph node positive. That makes him stage 3. And the stage 4 was a distant metastasis. So I could, if you want me to check specifically, we could also. Okay, sorry, give me like a second.
No, it's okay. I mean, you can let Eugene know check it. You can still present it. Okay.
Yeah, and then that's kind of a similar scenario with the other patient, except that for them it's for this guy it was finalized that he.
Sorry, sorry for interruptions in me, but we discussed this patient in the last lab meeting.
Oh yeah, okay.
Yeah, I will update you.
Oh yeah, I remember. Like, so we were censoring after his from his second signature.
Right.
And Hammond, this guy is very obvious. So he was actually diagnosed as stage 4 MA when he had bilateral pulmonary nodes were all PET avid. And then that was in January. And then his first return was actually April. That would make him not. So that was means 3 are off the list. Oh, so except this guy, he's still, but his second would be censored. But Larry D. Smith and Hammond, they are not really.
Yeah, they're stage 4.
Yeah.
Yeah, they're diagnosed as recurrent stage 4, so it's different than following curative intent patients.
Just to say, I think I was confused that with a landscape study, you could just have all the patients and present them regardless of when the ctDNA was done. Because I thought it was more like a description of the patient database you had. And now I realize from talking with other lab members that we have a specific criteria when it comes to looking at MRD with ctDNA in patients who recurred. So the ctDNA has to be prior to the recurrence. We have to at least have a sample prior to recurrence. That's correct, right?
Prior to recurrence. So we don't, the answer is no. If you do, let's say you got surgery and your ctDNA is positive, if it was just one time, you don't have to have a prior ctDNA. That in itself is meaningful.
All right. I'm getting confused. So, if he had curative treatment before and then recurrence, we could have a ctDNA after recurrence, and it still makes sense.
It still makes sense. If he, this is several years after, and this is when we know he has stage 4 disease. He got the blood bank. So this should count as a metastatic disease cohort, but this shouldn't count as a curative disease cohort. That's why I don't think he belongs in the curative analysis group. But let's say a had surgery and at some points gets blood ctDNA that's positive, and let's say he gets the CT scan on that day or a day after and finds out there is recurrence, that case still should be counted.
But not for this study, because we have curative intent. Um,
My answer is study.
이해를 못했어.
So let me explain it to you one more time.
Yeah.
If the patient is many years past, like Larry Smith, and we already know he has recurrent disease, and we're staging him, and we send for ctDNA, and it's positive. This patient, Larry Smith, should be counted as a metastatic group because it has been done as a part of already known recurrent metastatic case. Now, it's different if someone got surgery as a curative intent and gets first blood drawn at some time after that, not going to define how long after that, and gets a positive result. And maybe that would be the only result that you have in the file. Maybe you get a CT scan on the same day or a day after and discover that patient has recurrent disease, whether it's stage 4, whether it's stage 1. You just found out recurrent disease. That patient should be included in the curative.
Got it.
You understand?
Yes, got it. So Larry D. Smith would be counted, but Hammond because there's 3 months apart from his diagnosis of stage 4 recurrence, and then his first signature. So that would just be confirming, I guess. So I would say he's not. So it's what we need to take this one patient out.
We need what did you say?
Oh, so with Hammond, this is a progressive patient from the 21 patients that we had, the first group of patients, not the newly added one, and he's a progressive patient. And with him, he is not right for this particular manuscript, which looks for curative intent, because he was diagnosed as a stage 4 recurrence and confirmed months before his first signatera was drawn, and that was in April 2001. And whereas he had bilateral pulmonary nodes, making him stage 4 M1A in January 2021.
So he should be counted as a metastatic group.
Yes. And not as a curative group. And I didn't gather the data as extensively for the metastatic group. They're the majority, but I was focusing on the curative group when I collected the data.
So
and we analyzed.
was part of our abstract.
Yes, unfortunately, because I think I missed it.
Yeah. So this is why this brings up a good lesson. Okay. And this is something that can be missed, that if you don't read the charts deep enough. I mean, it's a lot of data searching and double checking. So I know you've worked as a team, Shuhee, Seungmi, and Eugene, and even 3 of you working together. It's difficult to exclude medical errors like this one. So that's why a lot of times, see how we change abstract. That's why people don't believe in abstract, because abstract, there's no peer review, and we're kind of under the deadline stress, and that's why people don't believe in the accuracy of abstract. Because when you submit the actual journal, they will go back and forth, send me your raw data and the protocol, and you have enough to double check and things like that. With abstract, a lot of things can be still in error. So I think you understood the concept of curative intent group, but in terms of really applying it to actual patient, it's harder to pick this up. And while the blood was drawn actually after the diagnosis of stage 4 disease, which automatically excludes the patient from our, study intensive, right? I just want people to know that it is a hard task, but thank you for sharing it with us. And when you don't know, so it's same thing. I think Janera might echo with what I say. Do not assume things. When you have doubt, well, you have to doubt it first. Ask, oh, does this patient really belong to this group or not? You have to ask yourself. If you're not convinced, ask people around you, ask your mentor, and you'll get the answer. A lot of mistakes happen because you don't ask.
Yes.
Okay.
So lesson learned is that I am very hesitant about asking, and also very hesitant about delegating things to other people or trusting other people or asking other people favors to double check. So I learned a lot from this session, this experience overall, that, proper teamwork means you have to have certain skills. Anyway, yeah, so this was a patient that I thought was progressive for it as part of the new group that wasn't part of the abstract, but then she had a really complicated history that took me a whole but I learned that by myself that okay, she's not right for a study because of the same reason for Hammond. Yeah, because it just shows you that you have to be very clinically aware and read the charts because she had 3 episodes of recurrence. And so in 2013,
what was her first Natera drawn?
Her first Natera was drawn. Oh, her signature is pending, but she's a new patient. I think it's pending. They did draw it within a month, but it's still pending.
Okay.
And I checked it 2 days ago. So
Okay.
yeah, so I thought, yeah, so she is someone who, yeah, basically at the end of the day, she had 3 recurrence of lung cancer, and I thought she got definite treatment each time, and eventually she was diagnosed with stage 4.
Okay. Any other questions?
No, other than I do need a lot of advice on Eugene analyzed the data when we took out, actually we took out Larry D. Smith as well, and I took out, by mistake, I took out Hammond, and she analyzed it and kind of togetherish, and yeah, Eugene analyzed it, and then we got the results for that. But I think we should reanalyze from your feedback. But the results are a little bit less significant than the abstract. So let's see. So there is some clinical statistical significance. This is reanalyzed when I took out the 4 patients, but now we know we could add 2 of the 4. So, I don't think we should show this. Okay, yeah. So we'll have to reanalyze, but because the results are not out, I'm finding it quite difficult on how to focus with the introduction.
Can I interrupt? Is it okay if we just reanalyze everything and then we write out the results section and then we bring it to you so you can read through it this week and discuss with us a mind map of introduction and discussion? Okay, so basically because we have to re-include people, so we'll just do we'll redo the analysis and we will write out the results. So we'll redo the analysis, write out the results and bring it to you. If you could go through it with us and help us structure out the introduction section and the discussion section, will that be okay?
Yeah, that's fine. I think so. Sungmi, my expectation is you finish this manuscript. When is your last day?
It's 13th.
13th. Okay. So I don't think you have much time. The introduction and discussion, 90% will be same thing, whatever, whether you get that significant p-value or not. Okay, so I would advise that you finish introduction and discussion regardless of the result. The part that will change according to the result will be about 20%. So you can leave that 20% blank and finish the introduction. You're the lead author, so you're responsible to work with whoever will help write it together.
Yeah.
I would strongly advise you do that part, whether the analysis happens, at what pace. But still do the analysis together. I think doing it together is a learning experience for you, all of you, because again, this project is not there for you guys to pad your CV. All of this, including Minjung's meta-analysis, it's there for you to have a positive experience, learning experience, that you, from the start to end, you're involved in the whole process, the double checking of the data, that with any future projects, maybe some of you won't do oncology, but the skill set and the whole, the process will be ingrained in you, then you are able to do the same on the same type of research in whatever you do with your next job. So I want you to learn from each other, but still I want you to be mindful of the timeline. And if you feel like it takes time for you to write, do it right now. Analysis, Eugene O can help. And it's still a very simple statistics compared to more computational work. This is, yes or no, logistic regression, and then it's the sample size is too small to do even any like anything multivariate.
True, that's true. It doesn't
So
show any.
yeah, so you have to be very primitive in terms like just maybe do a chi-square, yes or no, with very simple statistics, very descriptive, but do your best to see any correlation with anything.
Okay.
You're not gonna have significant p-value because of sample size, but regardless of still describe it. Yeah, and make it a very brief report, case series type of report. And did we decide on the journal?
Not yet, I think.
I think you said possibility of JTOCRR as a brief report.
Yes. So JTOCRR is your first bet. If not, clinical lung cancer is your next. Clinical lung cancer. And if not, there's a journal called Lung Cancer. Okay, so the three journals in mind, in that order. Any questions?
Yeah. So can you have a look at this thing I wrote and just it's just a 많이 부족하다고? Okay. Can you give us like an idea of what you think would be an ideal flow for an introduction and maybe some discussion points? Because I do know a little bit more about ctDNA world now, but it's really hard to come up with like a, I guess, an argument with the research I have, because there are a few similar research done previously, and yeah, ours is a little bit different in terms of we have small cell cancer and we have 1 stage for cancer. But oh, I need to, yeah. So I would like appreciate like a mind map for introduction and discussion from you.
So introduction,
Mhm.
over and over, starts with definition, the concept, what is MRD? Why is MRD important? Okay. And then the next is the knowledge gap. Are we applying MRD in lung cancer clinical practice? No, it's not in the guideline. No one uses it. We know it's important, and we know that MRD is predictive. And not only in lung cancer field, in colorectal field, it's commercial now. Signatera is commercial. Okay. Lung cancer, no one uses it. It's not in the guideline. Okay. So MRD research has blossomed recently and has shown really good correlation with patient outcome. And colorectal world has made it commercial, and a lot of people use it. In lung cancer, not in the guideline, people are not using it. So there's a knowledge gap. In the real world, real clinic, I don't know, is there a real world clinic data using Signatera? I don't know, you guys look it up. If there's none, this will be the first Signatera data applied in the curative setting. So that would be the meaning of this paper. If it's not the first, just say there's limited data, and we decided to explore the data and see in the real world clinic, does MRD, tissue-based blood MRD, does that correlate with patient outcome? We want to find out. Our hypothesis is it does, unless it's CNS only recurrence. Okay, that's why we did it. So it's always 3-part. The concept, MRD, it has become an important concept. Knowledge gap. Well, in lung cancer clinic, no one's using it. This is a gap that we have. Well, we heard it's important. No one's using it, and then we were saying, we decide to use it, and we want to show the world our experience. Okay, so it's 3 parts, always.
Okay, I have a question. So you want us to focus on Signatera,
No,
or you want us to be a little more general about it?
so MRD could be only blood-based, but Signatera took an approach using a tissue-based approach. So it's a tissue-based blood MRD. So I want you to focus on the concept MRD, but also explain that the method we use is a tissue-based MRD.
That's for discussion because like it increases the sensitivity and specificity. But then also one of the downfalls is that if we have a recurrence, then it's and the new mutation that wasn't in
and then it won't be detected. Like that's what we discussed last time, and also tumor heterogeneity. That's one of the. Do you want me to mention all of that about tissue-based, like informed blood tests compared to naive blood testing? Is that something all worthy for discussion? And then maybe I could have like a specific patient that could explain why maybe she was MRD negative because her tissue was sampled from maybe years back. And then her recurrence must be a new mutation that is not part of the 16 gene panel. These are stuff that I should mention in discussion.
Yes, it's optional based on the word limit, but I think it's good to have that discussion. So discussion points should be, it always,
Sorry, can I go over the introduction again? Just double checking. Is that okay? So basically for the introduction, first paragraph, you want us to talk about MRD. Second paragraph, maybe about Signatera a little bit and how it's tissue-based. And then third paragraph, you want us to talk about the knowledge gap, how it's commercialized in the colon cancer, but not so in lung cancer. And then go into the significance of our paper in that we deal with the real world clinic. Is that how you were thinking about the introduction?
Yes. You don't have to use the word commercial in the paper.
Oh, okay.
Just that say, I mean, it's now like it's becoming part of the clinical practice in colorectal cancer treatment, and it's I don't know, check the NCCN guideline or any other guidelines to see if it's there, like it's part of the guideline now or something that's better than.
Okay, sounds good. Thank you. Sorry about that.
One other thing, do we mention like NCCN guidelines as like the current standards? And we don't maybe not mention NCCN, but I did read it, and then of course they're a little bit conservative about it, especially in MRD. So it doesn't have it.
What guideline are you talking about? Colorectal or lung?
Oh, lung. And you're
So
saying
what
I
does
should.
it say in the lung guideline?
It doesn't have it in the diagram, especially if it's regarding as a predictive biomarker, using as a predictive biomarker. 아, 좀 헷갈리는데. Basically, they just want you to do the whole genes profiling. They're not happy with using blood. They're not happy with the sensitivity and specificity as of now to use it as a treatment discussion, just especially if you don't have tissue and only blood.
Okay, Sumi, are you talking about NGS or are you talking about MRD?
I don't think they have anything on MRD and NCCN actually. I think I'm talking about NGS.
Right. We're not talking about NGS here.
Yeah.
Point. So I don't think NCCN guideline mentions it in lung guideline.
Yeah.
Maybe it does in colorectal guideline. So look up the colorectal guideline and maybe you can share your screen when you find it. Okay, so look it up right now. And then I'll tell you about the discussion. So the discussion point, this is writing class 101, okay? So I just told you about how to write introduction. It's same for any other paper. Junaira and Arnie, same thing with your paper. So the way to write discussion for any paper, number one, why is my paper important? Okay, that's number one. We are the first group to show that this and this correlates with this. No, this paper is the first to show that this drug can work in this patient. This is the first paper that compared this method and this method. This is the first paper to show the utility of tissue-based MRD assay in real-world lung cancer clinic. if it's not the first case, just say just take out the first. A case that validated or something, that was proposed in colorectal world or something. But if it's the first in the lung cancer, then you have to be the first. That's why you have to have the paper out first. Because if you are late in writing it, you're not first anymore. Okay? It's a race. It's a competition. I'm sorry. It's just how it works. If you're diligent, you get the reward. You can be just me too. So discuss about the value of your finding first. Second paragraph have to talk about the history. So let's say lung cancer and MRD. What has been shown in lung cancer MRD field? Max Dean's paper is a classic one. D-I-E-H-N is his last name, Max, M-A-X. He's a radiation oncologist. He's a friend of mine. He's an MD PhD at Stanford. And he's written a lot of good MRD papers, okay? I think Charlie Swanton is another one, Charles Swanton. So those papers are good. Agarwal at UPenn, she wrote many good MRD paper review articles, and she has her own study. So talk about the history, that how a concept, and that I wrote nice article with Michael O, who is a UCLA Hemong Fellow, used to be a resident here. So so cite our own, you can cite our own review paper. Actually, it's good to cite your own paper. Kind of tells you you're an expert in this field. In that paper, there's a lot of things you can rephrase and cite for discussion and introduction, because we've already gone through the history and everything there, that paper. But that paper was written like 3 years ago. So there's newer information out there. So you describe what has been the progress in the field. And then you describe what is similar to the prior literature and what is different from the prior literature. Okay, so that's your second paragraph right there. So in the context of history, where are you? Like, you have to show people where you are. So that's your next step. The third is discussing each points. Why did we use not Guardant but Signatera? Why do I think there's a value in tissue-based approach? This is the value. What's our limitation? Well, if it's not the recurrence of the diagnosed tumor, if it's a second primary cancer, because lung cancer is so prone to use this term, cancer, field cancerization, you're gonna have different lung cancer pop up with totally different genetic background. So you're gonna miss those second primary. And a lot of times, if you just do histology and not do NGS, you don't know whether it's true recurrence or another new primary popping up. Sometimes you cannot differentiate. However, if you use these MRD assay, you're gonna have to know, and if it's truly coming from that clone that was resected, then you can detect true recurrent cancers, but you're gonna miss all this new secondary second primaries that pop up, versus other more like unbiased sequencing approach, like Guardant, will pick it up. So there's pros and cons, but those approach can pick up MDS, MGUS. They will pick up all the hematologic things too, and or they can pick up colorectal polyps that will secrete APC gene mutations. So you kind of at a loss of what you're picking up. So there's a pros and cons, and you can read many different review papers to figure out what's the pros and cons of these approach. People have already discussed it in length, but that's not the point. It's optional. If you're short, there's a word limit. You don't have to discuss it, but it's still good to discuss it at least with a couple sentences. So what is the strength of your approach? What is the limitation of your approach? And what is just the limitation of your analysis overall? Small sample size, and it wasn't designed prospectively. This was a retrospective. So the follow-up period, all these things are, variable. We didn't plan this prospectively. There's obviously no randomization, but it's just, so I guess you don't have to criticize yourself too much, but still, this is still hypothesis generating. This is, analyzing the real world and how it can show us utility. So it's to end with, future prediction. So we believe that this would continue to be useful in lung cancer field, and the lung cancer in general is the field that will benefit the most. Do you know why? And this can be an introduction or in the end of the summary of discussion or introduction, either one, because lung cancer is the one with the highest mortality. The lung cancer, even at stage 1, if you compare all stage 1 tumors, lung cancer has the highest recurrence rate, stage 1 or 2 combined. That is why lung cancer has such a high mortality. And this this is the setting where MRD approach will pay off. The challenge is there's so many different neoadjuvant, adjuvant type of therapies, and still MRD approach. You know what the biggest concern is? What if I have false negative? Okay. What if I have false positive? So there's that constant fear and concern. And I wrote this in my review paper. So you have to mention that drawback. Where do you graphic is, I don't see anything. Oh, I see recurrence. It's so, tangible. MRD is like, oh, some technology says there's something and we don't know why. There's nothing show up in the scan, so you have to believe it. So how can you gain that trust? My personal feeling is there is that level of trust now. Looking at the colorectal world, looking at Max Dean's data, there's such a strong correlation. So I think it's almost ready for prime time for lung cancer. It's prime time for colorectal world. I never knew this time would come this fast. Same thing with Grail for Juhi. I never knew they would make it commercial this fast. So the world is moving on at a faster pace. Now we're the end users, we're the oncologists, end users, and we are, writing this evaluation about, is this technology ready for prime time? My answer is yes, it's ready for prime time. If our data is not clinically significant, that's probably because of the sample size. But as long as we see the trend, we can be hopeful that this will continue to benefit our patients. So that's kind of the tone we'll be ending. And obviously the larger, more perspective validation study or case series or studies are warranted in lung cancer field, and with more data being accumulated, we need to assess whether it is ready to be incorporated into our clinical practice guideline. So that's how you end the paper. Okay, do you have the mind map now? And you're free to add anything that you think is important. outside what I mentioned. It's there for reference.
Oh, one thing I was just thinking, this is just something I was thinking, I just wanted to ask you. Like I think with false negative, this is not like a screening tool, but it's like it could be a adjunctive tool. So that's the way we could address it. But with false positives, like I should just mention that's like an issue. And the thing is, like, since your review in 2019, there seems to have been a few more journals, including in Nature, that I think you sent us, including that shows that the technology is advancing and they are getting more and more better at detecting smaller amounts of DNA, and not being able to see which ones are chip, from non-cancerous origin. And those are some things I can mention too, right? Like just
Yeah, briefly you can mention that.
yeah.
Evolving.
Okay, but I'll listen to this again, what you said, the mind map, and try to build my argument from.
Yeah.
Yeah.
So a lot of things that I told you can be written without the result.
Yeah.
Yeah.
It's true.
And it's a lot of referencing, a lot of delving into the literature and making your own logic. It takes time. You can't do it overnight. So you have to start working on that. Okay.
Okay. Yep. Thank you. With colorectal cancer, I think I need a little bit more time to read about ctDNA, but they definitely have like prospective multi-center studies of they're just clinical trials are more bigger, I feel like, than lung in
So
general.
are you not able to log in?
No, sorry, I just started reading from 3 minutes ago, so.
No, I'm saying in general, are you able to read NCCN?
Of course, I just forgot the password, so but I got the document. I'm just reading it. I just started reading it 3 minutes ago, so I can't tell you right now.
Okay, let me share the screen because I want you to look at it now.
Yeah. Okay.
But I want all of you to read NCCN guideline on regular basis. Can you unshare your screen so that I can share my screen?
Okay. Wait. I'm not sharing the screen. Oh, okay, sorry. I'm not. Okay, I've got it.
Okay. You guys see my screen?
Yes.
It's colorectal.
It's just too lower. Yeah.
No, it's not their guideline. Right?
There is mention of it in page 68. I'm in 69. There is mention of post-surgical ctDNA in page 69.
This one?
Yes.
Information from these tests can further inform the risk of recurrence, but panel questions the value added.
Yeah, it's a
Furthermore, evidence of predictive value in terms of potential benefit of chemotherapy is lacking. Therefore, panel believes that there are insufficient data to recommend use of multi-gene assay, immunoscore, or post-surgical ctDNA to estimate risk of recurrence or determine adjuvant therapy. ASCO has released similar recommendations regarding these assays, stating that their role in predicting chemotherapy benefit is uncertain. The NCCN panel encourages enrollment in clinical trials to help with the generation of additional data on these assays. Fair enough. So this is what colorectal experts, including our own Northwestern professors, so they convene, like all comprehensive cancer centers, they convene, sometimes in person, sometimes through Zoom, and they discuss this data. I don't think they discuss the Circulate Japan and the recent data. I think this is, so when was this version? February. So I think, I don't know when was the Japan Circulate come out, Eugene?
In ASCO session,
GISCO.
GISCO, yeah. I think it's around February this year.
February? Okay. Anyway, and sometimes they doubt if it's not US, they like, oh, that's Japanese data. We have to validate it in US. So they're very conservative to change their guideline. So their colorectal world. So when I say commercial, so this is you have to understand the nuance here. Maybe Chuhi, it's relevant for you too. When I say it's commercial because it has been validated by validated through a certain lab regulations. Okay, if you pass that, you can sell it. It doesn't mean the payers will reimburse it. So that's what's going on with Grail. It's commercial. It's not endorsed by any society. It's not, I guess, FDA approved. Did FDA? I don't know. So Juhi, does Grail have FDA approval? Do you know? Juhi, you're muted.
Hello? Can you
Yeah.
hear me? Can you hear me?
Yes, now I hear you.
Oh, okay. Apparently, they are approved from May 2019.
And what indications?
Breakthrough device designation by the US FDA. I will double check on that. I have no idea.
So the commercial space. Before Grail pursues. So GRAIL has a long FDA approval process ahead of it. But even so, health officials say it could be a game changer. I mean, these are written to gain more funds. So what I'm saying is you can sell product if it's approved by a laboratory regulation agency. But if the FDA has to do a lot of review to say this test kit can be used for this indication, because that FDA approval will affect payers. They will usually reimburse FDA indications. So a lot of tests or drug that we use are not FDA approved. They're just commercial. And we can use it for research purpose. We can use it for commercial purpose. And a lot of cases, patients pay out of pocket. Like GRAIL does that. How much is GRAIL? You know?
It was about $1,000.
Yeah, $1,000 out of pocket. No reimbursement because it's not FDA approved. Now, even if the FDA approves, if it's too expensive or for a logistic reason, it may not be reimbursed. So there's always going to be that gap. Now, a test or drug may not be FDA approved, but NCCN endorsed. Okay, then the payers are under a lot of pressure to reimburse it. And that only happens in the United States. I have not seen that in any other country. This is a country where expert opinions are valued. Okay. In South Korea, if Shinpyeongwon, its government agency does not approve it, then it doesn't approve it. Does not matter what group of doctors think. Does not matter at all. This is the NCCN has nothing to do with government, nothing to do with pharmaceutical, nothing to do with any agency. It's just a group of doctors like me, just meeting through Zoom, and we say, hey, this has really good evidence, and this should be part of patient care. And we put them in our guideline, and reimbursement parties respect it and reimburse it. I have not seen, UK doesn't have it, Canada doesn't have it. They all just go through, a government official has to approve it in order to be paid. So a lot of red tapes, bureaucracy there. But in United States, even if it's not in the NCCN, if I may, as a doctor, write a medical necessity letter to the insurance company, if patient file a lawsuit to an insurance company, even if it's not FDA approved, even if it's not in NCCN guideline, I've seen a patient of mine who's a lawyer file a lawsuit and won and got all his money paid. And there was not much medical evidence out there. It's not endorsed, not FDA, nothing. But this is a country where they will still honor your opinion and your desperate medical need, all that, and get it reversed. I think it's crazy. I think in a good way. I think that's a really good thing. It's a really good thing to work as an oncologist in this country. And compared to East Coast, West Coast, California, even more crazier. They will reimburse you a lot more things. So state by state, it's different. I'm just giving you a different perspective. So I'm telling you this when I say commercial, it doesn't mean it's endorsed. I thought the colorectal world endorsed. They didn't. They said we need more evidence. Clinical trial enrollment is encouraged. So, so there you go for your paper, Sungmi. it's not endorsed by guideline, but you can still say it is incorporated into many many GI medical oncology. It's in it the checking or the using MRD in determining the benefit of adjuvant therapy has been incorporated in some part of GI medical oncology community or something like you can because a lot of people are using it, whether it's endorsed by NCCN guideline or not. So you can at least describe it that way, and then briefly mention the colorectal world data and the lung cancer world data. But when you go into actual numbers of the hazard ratio, all of like when you actually go into the numbers, do not write it in introduction. Do it so in discussion. Introduction is only because conceptual. Okay. Okay. So this is a lot of teaching today. Nuances.
Thank you.
You're welcome.
So, thank you very much.
Okay, we have Juhi and Eugene. Let's take a bathroom break. 10 minutes and we'll be back. Juhi, are you ready?
Yep.
Okay.
Mm. You see my screen?
Mm-hmm.
Okay. So basically, I have
Your microphone's not working.
my microphone's not working.
It's working now.
Oh, okay.
Give me 1 minute. Let me get water.
I heard it from here.
Wait, I think yours is on.
Go ahead. Go ahead.
Okay, so basically this is the Vivian Panu case report. I have 3 questions. I have 2 questions. So like Albert Curie's case report, I think we're going to include a timeline because the things that she received, all the medications and stuff, it's kind of confusing. So I thought I'll make well, Arnie is gonna help make a timeline for that. Just to explain it better graphically. I have 2 questions. I have a question understanding the Garden and Signatera data. It's out now. So the April data is available and I copy pasted it here. But if you see the values, it's increasing.
Yeah.
And I was wondering, like, how would you want me to narrate this?
So we have two options.
Mhm.
Wow, I wouldn't say it's really an option. We can censor we can censor it to the time point where we didn't see this molecular relapse, but I think we should learn from this case. So Signatera and Guardant both showing increase in molecular markers,
Yes.
which means that the future scan may show progression. So to get a complete story, I think she'll have scan in next 3 weeks or something.
Okay, but I'm not sure if it's right to include that just because then it feels like it's discussing a new point.
That's true.
And then the case report will just be dealing with too many stuff. So
Too many stuff, yeah. So you don't show me the Guardant one more time, yeah. So the P10, so tell me when the mTOR was given, the temporal illness. When was it? When did it start?
one sec. I deleted all the dates. December.
December. Oh yeah.
Okay. So I guess the Guardant and Signatera,
Signatera had one in February.
and that was decreased, right?
That was decreased.
Yeah. So we have that. And look at Guardant. The only one is April.
Garden?
Yeah. I guess
Yeah.
after
The only one after temsirolimus is April. Whereas Signatera, they had January and February.
yeah, which is good.
Yeah.
So I think if you don't want to talk about the relapse after temsirolimus, which is another story, why the relapse, I think it's fine to cap it at, what is that, February,
Mhm.
and not mention Signatera in April or Guardant in April.
Okay.
And say, and then we actually don't have evidence of radiographic progression yet.
Yes.
So you can just mention the last CT scan being stable disease
Okay.
and submit. This is what happens if it takes long to submit it. More data comes out.
Okay, I'll finish it this week. I'll submit it before the next scan.
Yeah.
But I just don't want to bring up a new point because that's going to be more things to talk about in discussion and introduction and conclusion. That's just going to, I
Explode.
think, just steer away from the main points of
Right.
this article.
No, I agree. So apart from this paper, I think so the molecular progression precedes radiographic progression by usually 2 to 6 months. 2 to 6 months. So the next scan may show progression, or the next scan may show progression. Okay.
Okay.
Now the question is, this is just teaching points for you. Is it better to intervene when you know there's molecular progression? The same thing with MRD. When you have MRD positive, it's better to intervene then versus you wait for progression at radiographic or clinical level. So the ovarian cancer community has looked at it. CA-125 was their marker. Pretty good marker. The guy who developed CA-125 was one of my mentors at MD Anderson. So the lesson from a trial, let's say CA-125 goes up, you switch therapy versus you switch therapy at radiographic progression, there was no difference in overall survival. So there's a downside in starting chemo earlier. Patient can die of chemo. You understand? They get infection. Versus you wait till there is symptomatic progression, they do well. They still maintain good quality of life. So you wonder, is checking biomarker really helping patient live longer? No. Is giving them a better quality of life? Probably not, by giving less chemo-free days. So you have to think, like a critic, like, okay, biomarker is helpful, but is it really impacting quality of life?
But then wouldn't it give the physician, I guess, enough time to prepare for the next course of treatment? Because if you know that progression is coming, then you can do more research into what treatment options you can, I guess, present to the patient in the months to come.
That's a really good point. So this trial has been done where there's like chemo, there's only carbotaxol and maybe Gemzar. So there's no research, there's no NGS, there's no nothing. It was a primitive, let's say 10 years ago. There was no immunotherapy, there was no targeted therapy, there was no NGS. It's a dark age. Everyone got carbotaxol and hospice. So this age is not normal. This is a unique age. And you can argue maybe we can, if you have EGFR mutation, you can start Tagrisso first, just to treat MRD. So the same type of trial may be very different outcome, but at least what our data with CA-125 is no difference. But now we have good biomarkers and good targeted therapy options, more and more options. So I think buying that time to do more research, I think it will help, but it's still our hypothesis. No one has actually proven that within real world perspective study. But anyway, I just wanted to give you that perspective.
Yeah, thank you.
Wow.
And I have another question. So, because I need to start deciding on CT scans to include. Well, we already talked about it and decided on which CT dates to include. But my confusion is which, I guess, image from that CT scan to include. Do you just want us to include the biggest mass or the criteria we used for racist? Like how, I'm not exactly sure.
If you want to show response, I would
Yes.
suggest you show the biggest difference
Oh, biggest.
before and after.
Okay. Oh, okay.
Yeah, because that's what you want to show, probably the response. And I would suggest at least use two image, like not just one lesion, but maybe two lesions, for example.
Okay, okay, sounds good. Do you think one of the images should be a lung, or that doesn't really matter?
Doesn't really matter where.
Okay. And yeah, that was my question. I don't think I'll be able to get in touch with the pathologist. I tried calling them again, but they just told me to leave a message, which I did last time and this time, but it's still no response.
It's okay. Pathology is not that important.
Yeah, I don't think there will be a
Now,
pathology.
She
So-
just had PET scan. So
Oh, she had a PET scan?
yeah, so there is a big difference in FDG avidity. So I suggest you have two CT and maybe two PET images to show difference in FDG avidity. If they happen to be the same lesion, then maybe you have to pick one. You don't have to show one CT and one PET.
Wait, I'm a little confused. So I have CT scans for 4 dates, and I'll include 2 scans each for each date. And you want me to include PET scans too? The
Yes.
current one and the one before, or just the current one?
Before and after.
Before and after. Okay.
But my point is, if the CT scan already addressed one lesion, you have to pick and choose.
Okay.
There one lesion, the difference is better represented in PET or CT. I don't
Okay.
want to overlap there.
Okay, sounds good. Okay.
What journal are we aiming for?
This one was JCO Precision Oncology.
Okay.
Eugene was wonderful enough to write the discussion part. We'll finish it up. We will finish up the whole thing before the next scan. So this week, I'll
it.
finish up the selecting which scans, clean up the article. Hopefully it's done by next week
Okay.
for this one.
So just writing one case report is not easy, right?
Yeah,
True.
especially because I know nothing.
It's a good way to learn clinical knowledge. It's yeah. It's better than reading just textbook and NCCN guideline. It's
I agree.
yeah,
think-
doing this,
yeah.
know how biomarkers are incorporated and yeah.
Eugene, did you have a comment?
For discussion, I'm on the process of finishing it, so I will present it next week or next
My
time.
suggestion is read JCOPO guideline.
Mhm.
You format everything according to it when you write. Have the word limit in your mind. I don't want you to write way more and then having to strip,
Okay.
Mhm.
cut down. When you write, have a clear picture. Oh, first paragraph would be about 4 sentences. Second paragraph is going to be about this and it will be about 3 sentences.
Okay.
Have and then this would, approximately fit the guideline of word limits. So I want you to start with a clear picture in mind. Do not
Mm,
just write, and then like a lot of people spend a lot of time cutting down and reading the guideline later on.
makes sense. Yeah.
They
Okay.
didn't have an abstract portion, but do you think we should include an abstract portion?
Oh, JCOPO papers do not require abstract,
Yeah.
but
The word limit is very generous.
100, 1,500, I think.
can you
Yes.
see our JCO articles that have some do have abstract?
For case reports,
Oh, for case reports, you don't have to have abstract.
oh, okay. So
I think for original article, they do, right?
yeah, I was talking about case reports. They didn't require an abstract. So I was wondering if you wanted us to include an abstract or if it's fine the way it is without an abstract.
Without abstract is fine.
Okay, sounds good.
Case reports different.
Okay, those
Oh,
are
wait,
fine.
wait.
Because Albert Curie has an abstract. That's why I was asking.
This is Vivian, right?
Yes, this is Vivian.
Okay. I had an interview with NM Media yesterday. Now I looked back at her pathology report, and it does say poorly differentiated thyroid carcinoma.
Yes.
Is it the same thing with anaplastic?
No, they're not same thing.
Not same thing. Okay. Poorly differentiated. Yeah.
I thought she had anaplastic, but when I reviewed her pathology, it is poorly differentiated. So you have,
Oh,
right? It's not, take out everything that you wrote about anaplastic.
Oh, they're
oh,
completely different.
I assumed.
This is what I wrote. But I guess
I did my best to find anaplastic in any sort of official report. I couldn't. So clinically speaking,
interesting.
they're very similar, but they're not the same thing. So anything that you cited, you referenced about anaplastic does not apply to her.
Okay. I
So
think I
take
should
it
make
out
a
from the
twist.
title as well.
okay.
That was my bad. I assumed that because I treat her as if she is anaplastic. And I always thought of her as the most aggressive category, and she is. But for scientific writing, you cannot say she's anaplastic. She's poorly differentiated, which behaves like anaplastic, but it's different. So that's a big change. I'm glad I'm telling you now versus you. So this is another thing. Don't believe everything I say. I have distorted memory. Okay. For something like pathology, you have to read the pathology report yourself. You cannot just go by what I say. Okay.
Yeah, I thought I should have studied it. I thought it was like a subset or something.
Yeah.
But yeah.
Um, okay.
Okay. I'll delete the first part. The second part was from the pathologic report, so the second part is correct.
Okay.
Okay. That is it for Vivian. Wait, then I think we need to change the timeline because we'll have to go through everything we did in introduction and discussion because the articles will not be relevant anymore. So it might take a little longer than I thought.
Sure.
Yeah. Okay. Um, then for the review, the cancer screening review. So we went through the first screening. Um, big thanks to Arnie, Zuni, Eugene. Um, so I have some notes from the first screening. So we're gonna start up the second screening. I'm gonna allocate people today, and so they can start the screening process. Basically, what I want, basically we have about 300 to 400 articles. I will compile them together um and give you the exact numbers later. But so basically what I want from this second screening is for people to classify the articles based on these five categories that I thought about, but with Eugene's help. But I wasn't sure about the third category that I wanted to run it by you. Um, so some articles had done screening based on blood and based on something else too. So they did two stuff. Like they looked at the urine and the blood. should we include those articles or should we exclude those articles?
If they have a blood only result, yes. If they report it in a way they combine everything all together and report, then you can't say this is a blood-based assay. This is yeah. So I think we have to be strict. Or
Okay.
reporting, yeah.
Okay. And a lot of the articles tried out something. Like for example, they tried out like looking at hypermethylation and stuff like that, and they ended the article by saying that, oh, like this should be incorporated into the screening process in the future, kind of thing. So would we include that article thinking that because they were successful, or would we exclude the article because, well, technically they tried it out on people and it worked, but it's not exactly like a what how should I say it? They just ended by saying that this should be included into like a screening process. Eugene, do you know what I mean, right?
Yeah, so maybe if I can add, like there were so many more articles than our imagination that look into the, trying out so many different variables to predict the cancer. So it's, to me, it seems like it's in the preclinical stage, like not like the prevalent methods or not that many used methods, other than that there are so many, just one particular test, and they reported results as well. But I don't think, like, I'm not sure, should we embrace all the stuffs as well, or should we be more selective on the main methods? Or
I don't understand your question. Trying out, what does trying out mean?
so basically, so there are many reports in which researcher analyzed only hypermethylation pattern of one specific cancer. Do you think we can integrate that information as well in our review? Like they find some particular 4 gene hypermethylation in cancer patients compared to the normal patients, like in blood. But I'm not sure I can say that particular 4 hypermethylation pattern as a diagnostic tool or method. They just found that results, but I'm not sure they can
The
be
article, I need to know.
the specific.
So we have to say if it follows the rule, you have to report it. If it gives you sensitivity, specificity, or predictive value, whatever the outcome in general population or even in high risk population, then you have to report it.
Okay.
We can set a sample size. Let's say if there's too many and it's not worth looking into 20 patient result. Like 20 patient, it's too small. So if you get an idea, like how many samples do they actually look at? Do they just look at 10 patients? Then maybe not worth reporting.
Okay.
Well, but we need to know the sample size and see if we're dealing with too many, low sample articles. Maybe we can then decide our new cutoff for
Depending on the
sample
sample
size,
size.
because we don't want to review, they looked at methylation pattern in 10 patients. That's too much.
It's too little. Okay.
But I don't know, I think maybe the ballpark. I mean, if they're doing case control, so there's a population study looking at incidence. But then if you wanna do, because a lot of people wanna look at case and control and do a training set, validation set.
True.
And can we distinguish cancer patient, with the normal patient? So that's case control study.
Mhm. There are some, but
Yeah.
there are not. Yeah.
But how can you say sensitivity, specificity that if you don't know who's cancer, who's not, who's normal, right? So you have to know the outcome,
Okay.
whether it's
But-
prospectively followed or retrospectively done as case control. I think, I don't know, my ballpark number is maybe 100,
Okay.
Uh,
We will.
but we'll see what the articles.
Yeah. Okay. We will. Yeah. I think we can show you a few articles next time, like with all the statistic they have, and then figure out whether to include them or not.
Okay.
Okay, sounds good. Yeah, so I'll give out the EndNote file to people today. We will divide up and we will make the following folders, the 5 folders, and assign articles in each. I want 2 people going through the same article. So 2 people will be a team. There's going to be like 6 of us, so it's going to be 3 teams. We'll have a preliminary meeting on Thursday or Friday, depending on everyone's progress. And we will set Monday noon as the deadline for the second screening. And so after Monday, hopefully next week, Tuesday, we can begin the extraction of data and start to find a trend and write out everything. Is the timeline for now. So there are 6 of us doing it. Arnie, Zuni, Leanne, Eugene, Sunny, and myself. I know undergrads, you suggested Sally and Dean to help us. I was thinking they can help us after the screening process when we're actually extracting information into a table. Just because like,
Yeah, I think that's
Yeah.
better.
yeah, okay, sounds good.
All right.
That's all I have.
Okay. So same thing for you. I know you're doing that, but when you have, I think you'll be pressured by the deadline. But if you can, it's the discussion and introduction, the history of the literature, where we are, that kind of things can be still looked into while you're doing this.
Mm.
Yeah.
So,
Okay, and then you have a presentation for next week about the commercial landscape.
Yeah.
Okay. Anything else, Jui?
Nope.
Okay, thank you. Eugene?
Yes. So for me,
Mm.
I have only 2 things to discuss with you guys. So first, I'm going Dr. Shi, do you want me to present about the Japanese trial?
Yeah.
Circulate. Okay. Just give me a sec. I'll share my screen. So can you see my I think you can see the screen, right?
Yeah.
Yeah, so I'm gonna summarize the Circulate Japan trial today. So before moving on, I want to introduce an original study that provided a concept for this trial. So it was an prospective and observational biomarker study with stage 1 to 3 colorectal cancer patients. And the aim was to demonstrate postoperative detection of ctDNA is associated with residual disease and high relapse risk. Signatera was used and preoperative MRD was positive almost 90% of patients, as reflecting the composition of relatively advanced stage cancer. So basically 2/3 of the patients were stage 3. And after definitive treatment, longitudinal ctDNA analysis identified 14 cases out of 16 recurrence cases, which is predictive value was 87%, 0.5%. And the patients who was ctDNA positive at post-OP 30-day had recurrence more than 7 times compared to the ctDNA negative group. So ctDNA at post-OP 30-day had quite prominent association with relapse. Now let's move on to our original paper today. So based on the idea of the previous study, a group of researchers in Japan designed a nationwide ctDNA guided precision adjuvant therapy project. It was formed by putting 3 different clinical trials together. So Galaxy is the observational study, and Vega and Altair are 2 randomized phase 3 trials. This shows how 3 trials are connected. So in the middle, Galaxy study is an observational study where patients are going to be monitored pre and post-operative. And based on 1 month post-operative ctDNA results, if patients are ctDNA negative, they're going to be randomized to either no chemo experimental arm or the CAPOX control arm. Basically, it tries to de-escalate treatment. In contrast, if patients are ctDNA positive at post-OP 1 month, they're going to be randomized to either FTD, TPI, it's abbreviation of the treatment, experimental arm, or the control placebo arm. So it tries to escalate standard therapy to another level. So it's called escalation trial. So let's go into a little bit deep.
Go back.
Mhm.
So one is 3 months, one is 4 cycle.
Yes.
Are they same or?
With detail about the treatment plan.
You know why they're written differently?
Oh,
One,
why
3
they're
months, 4 cycle.
Actually, I read through the whole this trial article, just introducing the trial, but I cannot see why they put it. I honestly I don't know. I don't understand why they put it differently as of now. But
And this positive ctDNA is that, are they?
they're using Signatera, and the time frame would be 1 month plus minus 7 days after curative treatment surgery.
Okay. So what is the next R? R n equals 240. What is this? You get K-pop 4 cycle and then you get randomized.
Oh. In case of performed. So So for this, the box colored orange, it's Arter trial, and it can I move on and then explain it a little bit later?
For Altair.
For Artel, it's a little bit different from other two. So post-op ctDNA positive group is regarded as they have high risk of recurrence. So according to the guideline, they have to given Capox 4 cycles, and then after that, if they still show positive ctDNA, then at that point they're gonna randomize the patients to the FTD TPI arm or the control placebo arms. Maybe they might continue for the control arm, they might continue to give them chemotherapy for more 6 cycles after 4 cycles.
Placebos? 6 cycle?
Mm,
I don't get it. Let's
Okay,
read
so-
more about it. I don't.
okay. Okay. Can I? Yeah. Okay. Do you want me to go to the directly Arter trial then? Because Vega and Galaxy is kind of a little bit easier to understand.
Yeah, go through the Vega trial first.
Vega, okay. So for Vega trial, they will include the post-op ctDNA negative patients at post-op 1 month. So the purpose is to test whether post-op surgery alone is non-inferior to the standard Capox chemotherapy. And so for randomization part, the Capox therapy, it's gonna be continued for 3 months, like this regimen. And the primary endpoint is disease-free survival. And regardless of this, apart from that, the ctDNA monitoring, they all gonna be surveillanced by CT for every 6 months up to 7 years. And yeah, so they made an assumption based on the previous study that I mentioned before. So they set acceptable 3% decrease in 3-year DFS as their standard. So associated with switching to no chemotherapy. And in terms of statistic, so for this trial, the non-inferiority margin would be 1.355. And for inclusion criteria, they will include only colon cancer, not include rectum patients, a cancer who has cancer in the rectum. And for to be included Vega trial, patients the needs to be completed on surgery with residual cancer considered to be R0. And they include patients with high risk stage 2 with this kind of relapse risk factor, and for low risk stage 3. And yeah, these are the detail in inclusion criteria. I think it's interesting to note CEA lower than 10. So they are trying to include patients who have at the least risk of recurrence, because they're gonna randomize patient into group where they might not get any treatment. They're just gonna be surveillance. And these are the exclusion criteria. And to me, like, most interesting thing was they want to exclude patients who have immunosuppressed conditions and other infections. And for Altair trial, so it's also a randomized phase 3 phase, and the aim is to establish the superiority of trifluoridine type puracil as compared with placebo in patients with CRC who showed ctDNA positive status with Signatera assay at any time after curative resection for up to 2 years after surgery. So I just brought, so and the other things are basically very similar to Vega trial. So I just brought brief summary of what FTD TPI is. It's a standard treatment for advanced or metastatic disease according to NCCN. And the significance of this treatment is the anti-tumor effect to 5-FU resistant CRC. So basically, arterial trial patients, yeah, so I brought it from NCCN. So for FTD TPI, it used to be given only after 5-FU based conventional therapy, but they want to give some patients this FTD TPI right after the first refractoriness to 5-FU. That's my understanding of this trial. And yeah, so for just to compare the Vega and Altair, there are huge difference between the inclusion criteria. Unlike Vega, in Altair, patients who have undergone radical resection of primary tumor and who have metastatic tumors will be included. And in case of patients with colon cancer of stage 3, they should have a past history of standard post-op chemotherapy. The way I understand it is because as of now, 5-FU regimen is the guideline, so they may require at least one trial of that conventional treatment before giving them FTD TPI treatment. And the other inclusion criteria are pretty similar. They require both ECOG 0 or 1 status. For Altair trial, exclusion criteria is pretty similar to the Vega one, excluding the patients with risk of infection or immunosuppressant. Yeah, so for discussion part, so Vega trial is designed to provide individual patient data into multinational collaborative project called Circulate IDEA. It's going to compare surgery alone versus adjuvant capox in resectable stage 2-3 colon cancer. And for ARTEL trial, the meaning of this trial is because there is no confirmative prospective trial developing therapy for resected CRC patients with ctDNA positive status, it's gonna be the first trial for this specific patient group. And so there is a interim report from Galaxy trial. So these are the, as of January 13 last year, almost 400 patients are collected, and these are the stage, the composition of stage, and the interestingly, over 90% patients had baseline ctDNA positive status. And as you see in the chart, positive ctDNA status post-surgery was significantly associated with advanced P-stage, PT, and PN, lymphovascular invasion, which means more advanced disease. And there were 13 patients with recurrence after surgery, and 10 were detected with positive ctDNA at 4 weeks post-surgery, which is pretty similar to the previous study. So with pretty high prediction value. And for 6-month disease-free survivor, so regardless of whether ctDNA was detectable or not at 4 weeks post-surgery, if they have ctDNA positive after 12 weeks, from surgery, it predicted pretty, it was correlated with a 6-month disease-free survivor. And for the ctDNA positive status at 4 weeks after CRC resection, it shows a more than 15-fold increase in the risk for relapse between the group with positive ctDNA compared to the negative ctDNA. And these are the data Liam received from a Signatera company itself. And it was not in the article itself. So
Really interesting. Okay.
yeah, so
So this was GI ASCO January this year. Okay.
Right, January this year. Okay, so I'm sorry, I pull up with the script that I wrote. So for this, they compared like ctDNA negative and positive group, and it shows so for ctDNA positive group compared to the negative group, the disease-free survivor was pretty poor, and it means positive group had almost 13 times more recurrence compared to the negative group. Disease recurrence. And also for 12-month 1-year disease-free survivor, so if, let's say, if patient has positive ctDNA at post-op 4 weeks, the 12-month disease-free survivor was 55%, but if patients showed negative, then the 12-month DFS was over 90%. And the difference was pretty significant, statistically significant. But interesting point here is that, so if I understood correctly, the positive results, the sensitivity data here. So when we consider sensitivity, so it means false negative rate would be 25%, which should be major issue for this essay, I think. So it means losing patients who deserve more treatment because they cannot detect ctDNA correctly. I'm not sure it's right to interpret this sensitivity as in this way, but that was my thought. And so when they gave MRD positive patients adjuvant therapy, it was effective. Obviously, adjuvant therapy did show benefit for MRD positive patients in each stage, in each different stages group.
So what are the color difference?
Oh, so the color difference, the green line means patients who did receive adjuvant chemotherapy, and blue line means patients group who did not receive adjuvant chemotherapy.
Oh.
And as you see here, patients who did receive chemotherapy did far better in terms of disease-free survivor. Yes, so for
Stage 4 is also very interesting.
Sorry, I didn't get it. I didn't.
Stage 4 is really interesting.
Stage
too.
4. Oh, in what terms?
It's probably like a liver only mets undergoing liver resection.
Mm,
Some gets adjuvant therapy as a standard, and it's not standard of care, but
okay.
some get surgery only, even if it's stage 4, but they do worse. This is not a randomized study. So if we know someone didn't get chemo,
Mhm.
sometimes they have surgical complication. Sometimes they have poor performance status. So these are people who will always do poorly. So there's a built-in bias here. We call it bias by indication.
Mm,
But only to get rid of it is randomization, which did not happen here.
okay.
Who chooses why someone gets adjuvant chemo?
Mm.
It's the doctors based on their clinical characteristics.
Oh, you mean that their clinical status was considered, so that it could make bias here. Okay.
But still, it's a big difference.
Yeah, true. So it means like basically 4 weeks post-op MRD positive patient might deserve adjuvant chemotherapy.
Yeah, everybody.
Everybody, yeah, regardless of their like clinical status
Mm-hmm.
at that time. Yeah, okay. And the last, I think this, the next data shows us that, so for, in contrast to the previous slides, it deals with the patients who showed 4 weeks post-op MRD negative. And it includes all high-risk stage 2, 3, high-risk stage 2, 3 colorectal cancer patients. And regardless of the adjuvant chemotherapy, their survivor or their disease-free survivor was equivalent. That means maybe they don't need adjuvant chemotherapy.
Yeah, so I think this is the best data they have. So I've been looking for this data. So this is a lot of patients. So we're looking at, 214 patients who got chemotherapy.
For
Okay,
no use.
for no use. And this is committing their 6 months of lifetime to this toxic therapy that might, some people go deaf. Some people get neuropathy that will not be cured rest of their lives. Some people get gram-negative sepsis and die from it. Okay.
True. And one thing I want to ask, or maybe I can ask to Signatera, is that I'm not sure if there is any data with adjuvant immunotherapy.
There is no adjuvant immunotherapy for colorectal cancer.
Ah, okay. Okay, only.
Immunotherapy does not work unless they are MSI high.
Oh, okay.
And I think they excluded MSI high here. That's what
Oh, yeah, that's why. Yeah, there in inclusion criteria, MSI was specified as stable. That's why they excluded high patients. Okay. In DEGA trial. I'll move on to the last slide. So here is another interesting data with sequential ctDNA based MRD assay. So it shows disease-free survivor by ctDNA dynamics from 4 weeks post-op to 12 weeks.
I think you have a problem with microphone.
Oh, you didn't hear me.
Can you guys help her fix it?
Oh, sorry.
Is it?
Oh, I did it intentionally to make it better, but okay. So also basically 12-week results seems to be more
Oh,
correlated.
not working.
Not working. can I just without my yeah, I'm sorry for not making more
Yeah, it's better.
so 12-week results seems to be more correlated with disease-free survivor. But if we take a look into it, I think it's interesting that there is a patient group with initial positive who converts to negative after 8 weeks, showing 100% of 6-month disease-free survival. I don't know, I can,
Where is
so,
that?
oh, so if you see the yellow colored group, orange colored group, they showed initially positive for ctDNA at post op 4 weeks, but it converts into negative group after 8 weeks. But if you see the 6-month disease-free survivor, they showed the best result, 100%. So I don't know if I can say those 62 here, 62, the below, 62 patients showed 100% 6-month disease-free survivor because of, so basically what I'm trying to say is that I'm not sure about the mechanism itself, but they showed the best results. And maybe it could be due to somehow our body can possibly remove that residual disease even after surgery with their own immune capacity.
So
And
you need to look into 62 patients, how many of them actually received chemo versus surveillance? Do you understand? Did they clear it? So I want to know how many of them cleared to negative without chemo.
Without chemo, okay.
If this is all chemo, 62, it's easy to understand.
Yeah, what the mechanism would be. Yeah.
If it's not no chemo in few patients, maybe it's our own body's immune response.
True.
Which is amazing, you know? So maybe look into it and let me know today, okay?
Okay.
If you don't know, email Signatera or email the author, corresponding author of this paper, and ask for that number if it's not there.
Okay.
A lot of times it's in supplemental data set, which you can only download through the journal website. Okay?
Okay, I'll look into it.
Okay.
Yeah, that's it.
So go back. Can you go back? So this is, well, go back, go forward. No, I'm saying go back to,
Okay, I'll show you the chart.
go back to the slide next to the last.
Second, this one. Oh yeah, this. I think this is the one you want.
No,
No.
one right next to the last slide. Yes, this one.
Okay.
Okay, this one.
Sorry. Yeah.
Okay, so this is relevant to Seungmi and Arnie, and I did talk about it before. So there are a lot of patients that Seungmi and I discussed that are not eligible, but they are eligible for the metastatic cohort. So our next project should be, and this is relevant for you, Arnie and Seungmi. And Seungmi, you're welcome to be involved as much as you want, but you don't have to. But Arnie will stay after you leave, and we'll work on the project. Would be the clearance. So in metastatic case, the clearance of ctDNA by Signatera, how would that change? So we need a graph like this, okay? Of course, everyone will likely be positive. So there's not gonna be negative to negative, negative to positive. It's more likely to be negative, positive, negative, negative, positive, negative. So we need to work on creating this figure for the rest of the group, okay? So that's our future project for Arnie and Seungmi and anyone who's involved. Okay, with Liam, you could be involved in this as well. So in metastatic case, clearance is equally important, and there are many garden papers that we reviewed. Seungmi has that paper. Looked at it. She reviewed the clearance data, and we talked about it. And you can share that with Eugene, Liam, and Arnie. But remember this for our future project. And ctDNA clearance for patients who is metastatic and received, it doesn't have to be immunotherapy in this case. Immunotherapy, chemo targeted therapy is predictive of response or better outcome, whether it's PFS or OS. I think that has to be looked at. So I just want to make that comment. Now go back to the first schema of the
trial.
the trial. Okay. So can you explain Kpox 3-month versus 4 cycle? What it means?
Oh, so your question is compare the blue box with Kpox 3 months with black box below that Kpox 4 cycles, right? You wanna?
One cycle is 3 weeks. Okay.
Oh yeah, yeah.
So 3 week times 4 is 12 weeks.
12 weeks. Yeah, I think basically same. I think it's same.
So they just, okay, so it's the same chemo is given, but the question is, from the Altair is after you give Kpox 4 cycle, do you check again?
Check again the ctDNA.
And do you randomize based on positivity, or does it matter?
Oh, that's
I think
you can go.
so I think okay, I think I got it. So actually I'm gonna go over to Dr. Eugene's computer so I can use the pointer.
Okay.
We're sharing this screen.
So I think what this is, so this dotted orange line box right here is the Altair trial. And so if you look here, all the blue lines are for ctDNA negative, all the orange lines are for ctDNA positive. So for example, here, if we look at the blue dotted box up top, each time they are tested negative and throughout follow-up, if at any point ctDNA comes back positive, then they feed into the Altair loop, or the pathway, which would be this right here. So at any point, if they turn positive, then they are randomized to the experimental arm or the control arm. Same thing here. So at 1 month post-op follow-up, if they are ctDNA positive, then you either go through the regular Kpox 4 cycles.
I think I can explain that.
Yeah, and then if not, and then if they are
so for the
continuing.
patients who who receive neoadjuvant chemotherapy, they don't require them go through again capox post-operatively. They will just go directly into the altar without getting the first cycle of capox, first 4 cycles of capox.
I see. I see.
Yeah,
Because
so basically
they
all of
failed 5FU.
arrows,
Because they failed 5FU.
the Altair solid orange box basically feeds into this dotted orange box because that's the Altair trial.
So what happens after post-op ctDNA positive got K-POX 4 cycle? What happens after that? It's done? No more checking ctDNA?
It doesn't show on this figure. We might have to go to the original article.
You want me to show the original article? I can show you. Or
Well, anyway, it's not shown here. What happens after?
okay. Yeah, I think that's valid point. Sorry, I missed that. So yeah, here I literally copied all the relevant information here, but I didn't show about that detail are out there. So key eligibility criteria. So they have to undergo surgery and they have to have a history of standard adjuvant chemotherapy of CAPOX 4 cycles. Oh yeah, I think they are monitored regularly with ctDNA, and anytime post-operatively, if they are detected with positive ctDNA, they're gonna go into the Altair trial.
And they don't have to have relapse by CT scan.
Yeah, no obvious and the key eligibility criteria, one of them is no obvious relapse confirmed by.
So go back to that figure again.
Okay.
So yeah, I guess the K-POX after 4 cycle, there should still be an arrow, right? Arrow, just like the Vega trial after the K-POX 4, right?
Mm-hmm. Oh yeah. There's missing arrow.
Yeah, so it's going to be checked and only if. So Liam, I think you can use this paradigm for our lung cancer diagram. So it's easy that to maybe try this paradigm where different colors with arrow. So that will make your schema but more succinct, simpler. That makes sense? Maybe for the lung cancer trial, you could do something like this.
Yeah, I'll think of I'll
I'll think about it and maybe we can confirm together what would be the best way. So anyway, yeah, good. There's an arrow, but then there's could be, it could be like a like a blue arrow, but then at any point it can go to Altair, right? So same thing.
Yeah. I'll definitely look into it. It does look nice with all the color.
So what's unique about this trial is very similar to what we designed with lung cancer trial. There's de-escalation Vega, and there is escalation Altair. Do you know why Japanese did it? Taiho is a Japanese oncology pharmaceutical company that makes Lonsurf. Lonsurf is FTD TPI.
Oh,
Commercial name for FTD TPI, and it's a pill.
is it ethical?
They're the only company that makes it, so they want to prove. They want to expand their market. So that's why the pharmaceutical company is paying for this trial. And it's a smart way to do 3 different studies at the same time. And they make it different names for each one. I think it's smart. I like the design very much. And I think Liam and Eugene, we should think hard to learn from this trial and apply it in lung cancer setting.
True. Agree.
Yeah. The 3 months and escalation, de-escalation is pretty much same. What we need to learn from this, Eugene, is how they allowed acceptable, the hazard ratio. Can you go back to that?
Oh, acceptable. So non-inferior margin, you mean?
Yeah. So 3-year DFS, 91%.
Yeah, so to compare whether the observation is non-inferior or inferior, there should be some criteria to decide that. And I think they put 3% as their criteria. So if observational group has less than 3% of difference between the treatment group, they're gonna decide that's okay to accept. To the 2% only, let's say if 2% less disease-free survivor, that's what we can accept. But if that's over 3%, we cannot decide patients to not receive any treatment. I think that's what they're going to try to say.
So 1.355, is that a hazard ratio?
Oh, it's non-inferior margin.
What is that?
So non-inferior margin is a predetermined margin of difference between the new and standard treatment that is considered acceptable or tolerable for the new treatment. In this case, the observation, to be considered similar or not worse. And based on this number, they calculate a total of 1,240 patients will be needed to provide 70% of power at one-sided significance level of 10%. So yeah, I think you can understand 1.35 as like hazard ratio, but it's not technically the hazard ratio itself, but.
So just a predetermined number, kind of like the p-value, you kind of decide the p-value before going into the study. So that was like their acceptable margin that they were going to accept as non-inferior. So they were okay with 3% decrease in DFS, and they were still going to say, okay, it's non-inferior.
So how about Eugene and Liam, both of you study the clinical trial statistics, whether it's YouTube or internet. There's a book here as well. So how did the authors come up with 1.355, and how do you calculate 1,240 out of this equation? And it's pretty crude. Like 70% power is pretty low.
True.
Like if you want to get to 80%, you probably have to double the number. 2,000. So the trial becomes really costly. But you got to compromise at some point. And significance level is 10%, which is not super. Usually it's 5%. Anyway, it's all compromise, but how far can you go to compromise? That's another question. So look into the field, for these adjuvant trial, how do they design it? How do you design non-inferiority trial? And how do you actually get to these numbers? And how do you do the statistics? I want you to learn from this trial and then apply it to lung cancer trial so that when we propose, we have number need to treat. And in lung cancer field, what is the acceptable decrease? What is the model we can use? I think Max Steen's data has pretty good number. I think Signatera have some lung cancer publication. It's Charlie Swanton's group. So look at the historical numbers. What are these numbers in lung cancer? And how can we apply these numbers so that we can come up with number need to treat for de-escalation trial for lung cancer, like Vega. That's number one. Same thing. What's the statistics they used for superiority trial, which is the next trial? What is that?
Arthur.
Do you have statistics for that?
Oh, no, there were no description about statistics in that part. In the original article, yeah.
Because probably they did not report the result yet. Right?
Right. They did not report the result about this specific Arthur and Vega. But I'm so sorry. Let me share another screen briefly. I think I missed this part. So this is the Alter trial description. They do have statistic description. So a total of 240 patients will provide 80% power to detect an expected disease-free survivor hazard ratio of 0.0667. I think this is 2/3.
Yeah.
At two-sided significance level of, oh, there's a difference. So in Vega, they used only one-sided, but here they used two-sided. Which I think I have to think about more. So I will definitely look into the statistics and then study more about it.
So this is, checking to see if it's superior or inferior. It's looking at difference. That's why it's two-sided. If you know, you can do one-sided if you know it can only work in one direction.
Oh yeah,
So this is a new drug, and people can, have harmful effect from it too. Like you can make it two-sided in that case. So anyway, this is all about clinical trial statistics. So maybe, how did they come up with 0.667? Is it just that it will get better by 2/3?
They don't. They don't give any explanation.
The random number they selected, most likely, but look at other trials and look at the textbook of clinical trial statistics and see what are the most widely used accepted methods to prove that the new adjuvant therapy is effective. And same with our lung cancer trial, we could come up with the number need to treat in this way.
Okay.
That's your like a thing to work on, both of you together, and present next week in that meeting. Okay.
Okay, got it.
This is a real world thing. This is very interesting. Anything else, Eugene?
So for the only other thing is the Albert Curie case report. Let me just, I think I can finish that up within 5 minutes, I think so.
Okay.
We will share. So thanks to all of the other lab members' help, I was able to contact all our target journal, and only JTO and PLOS Medicine showed favorable response to us. So first, I decided to shoot for JTO, and so here, everyone helped me in different ways. So for JTO, they only allowed us to write less than 1,000 words. So I made it very succinct. So this is abstract, introduction, case presentation, and discussion part. EASL had a second look yesterday, and she gave me a lot of very productive comments that I think I have to work on more. And I just want to confirm about the figure, just on that part, Dr. J. So I know it's not high resolution. I will definitely improve my resolution, but this is just the idea. So my plan for figure 1 is that the title is like this: clinical course of timeline of therapies and patient response, baseline and follow-up CT scans after transplantation, and minimal residual disease after transplantation. So figure 1 will contain 3 different graphs, and Arnie helped me a lot, and Arnie will take charge of this when it is confirmed. So do you think it's reasonable to put all of things in this way?
Can you go
Or-
back up?
Well, I'll just make it more presentable. So it will be in a same figure, all 3 components. Like this.
So I don't understand. How is the figure going to be?
The figure 1 will contain 3 components. A would be this arrow containing graphical image. And it's gonna be titled as timeline of therapies and patient response.
So
And-
are you gonna make it more like each
Yeah, just
stacked after each other?
yeah, like this.
So
So my question would be, because I know that you want us to specify the 3 times of biopsy, you think it's worthy to mark that biopsy as well in this arrow? And also, I'm not sure about whether I should include Garden's result in this arrow as well.
you don't need garden result. So you can put garden result. You can describe it in the text, an
Mhm.
actual table for each different time point. You can put those tables in the supplemental data.
Oh, you wanna make a, okay, you want me to make a table for Garden results.
At different points.
Okay. And for the CT scan and X-ray, this is the one that that Isol used for her abstract submission. Is it okay for me to put only 2 time points? Maybe should we include more, like the CT or X-ray? As of now, I only put 2 months before surgery, 2 months before transplantation, and 5 months after surgery. That's
So instead of word surgery, I would put transplantation.
okay.
I would not put the
Do
other
not-
thing is, if you are making a figure panel, it's one graph. So you have to make a huge big panel and really put A, B, C and make that as a one picture file.
True, yeah, that's what I'm gonna do.
So you'll do that, but for review purpose, it's okay.
Okay.
And when you actually submit, this is for everyone. You like this format is for us to review, but in actual submission, figure is all picture files. And so the order is, you have main text, you have reference, you have figure, title, and legend. And then you have table. You don't actually put actual figure into the actual manuscript.
True.
Part of the picture files that you upload separately.
Okay.
But for us to review, it's fine.
Okay. And lastly, MRD. So basically, for Albert Curie patient, so for the patient, he has shown no MRD in plasma. So the graph, I'm not sure whether the graft is necessary or not. Maybe,
Yeah, I wish we had pre-transplant value, right? But he never had one, right?
right. We had pre-transplant garden results, but not MRD.
And post-transplant garden, do we have just one value or two?
Post-transplant, we have 3 gardens.
Okay. When is pre-transplant?
So there were 2 pre
March and May?
March and May.
So let's see, we have TP53,
TP53, the
NRES,
yeah, and MAP K3.
MAP K3, and then TSC is gone. But they-
NRAS has gone.
but
Oh
they're-
yeah, TSC has gone. Yeah, true.
They're
Sorry.
same clone.
Yeah.
So my interpretation of this is that because they are not, well, because they're the same clone that was present before transplant,
Mhm.
that even though tissue-based PCR, which is Signatera, shows no molecular, no MRD, the Garden is showing a possible MRD because they are the same clones that were present before surgery. So the Garden test shows that MRD is still positive, but it's not increasing,
True, not increasing.
stable. So whether it will remain stable, and it's not increasing despite the fact that he is on immune suppressant, is still a favorable, as long as the MR. So, so maybe you can make an argument that if you know in Japan circulate what proportion of the positive to negative were people without chemotherapy, you can use that argument for this patient, saying that as long as it's cleared or stable, does not get worse, maybe our immune system is able to function and do its job. We call it immune surveillance or immune editing. And we talked about Bob Schreiber's paper,
Yeah.
introducing that concept for the first time. So you can cite that paper. You can cite Japan Circulate GI ASCO presentation showing that positive to negative conversion, and say maybe as long as Albert's immune system is working to keep the MRD levels at stable rate, this may not turn into a recurrent disease, clinically or radiographically.
Interesting. Yeah.
Yeah, but also stress the fact that Signatera has been consistently negative. And I think that means something too. But I've always noticed that Guardant has the best sensitivity. And
Oh,
that is lost, I I guess, is missed by other companies' tests gets picked up by Guardant.
Mm,
Call it barcode technology. In my clinical experience, they have the best sensitivity. So no wonder, I'm not surprised that Guardant is picking up this while Signatera is not picking up.
mm,
Okay. But
yeah,
I
okay.
wish this was all non-detectable, but it is, but we can't hide it. So I would rather put this in the supplemental figure
Okay.
and put only Signatera in the actual figure, okay?
Okay. But just to clarify, you want to make a table from this garden data, like table as well, like showing the extra for variable alert frequency, like percent? Or is it okay to just put this on supplementary figure?
I want you to make a table
Okay.
with each time point,
Mm-hmm.
and also you can't put actual dates. You have to put, 3 months later, 2 months.
Oh yeah, relative date.
Yeah. And then with the table, you are able to put functional mutation, VUSs, and their allele variant frequency at each time. Here you're kind of guessing. There's no number here.
Oh yeah, got it.
So you in a table you were able to convey,
More
more
concrete.
information.
Thank you for your advice. Yeah.
Yeah. It's deep. The science is deep.
It is. Yeah. And just to give everybody like a story, like I found that in JTO there was a case report reporting the very same case like Albert Curie, but it was in the 20th male patient, I think, and he ended up getting 3 recurrence after lung transplantation for leopatic adenocarcinoma. Leopidic, yeah, which is included in our
your screen.
Oh, okay. Interestingly, he lived 13 years after a long transplantation, which is sad, but at the same time, I think it's remarkable. Did I? Oh, it's here. Okay, I'll pull up it. Yeah, this is, can you see? So 13-year survivor in a patient with diffuse bilateral lepidic predominant.
Oh, this is the UT Southwestern. This is where Dr.
Oh, Jimin is here.
Min Hwang is going to start
Residency.
And David Gerber, I know him well. He's
Oh,
a thoracic medical oncologist and phase 1 doctor like myself. We have many
Oh.
similarities. David Gerber is a great mentor and definitely, good. Yeah. So UT Southwestern, such a great center. And this was published in 2020. Okay.
But they reported this case after 13 years of lung transplantation.
Oh, okay.
They kind of provide us with the whole like clinical course, unlike us. We will report, if we're accepted, we're gonna report like very recent transplantation case, but they reported pretty, yeah.
Yeah, show me some figures.
Figures, okay. So this is figure. So they have initial diagnostic chastity, which is not the case for us because Curie came to the hospital just before transplantation a few months.
Yeah, we don't need this. It's okay.
Okay. These are the figure, and Oh, actually, he went through 3 times of recurrence. They provided us with each recurrence CT scan.
So what's the one right before transplant?
I don't think they provided that with us. They just provided the CT for initial diagnosis period. And then the next figure is first recurrence. They didn't give us, yeah. And the next is second recurrence after 42 months. So 17 months and 42 months. And then last recurrence was multifocal, unfortunately, and it was after 139 months. Yeah.
How old was the patient?
The patient was so young. I mean, unlike Curie, 33-year-old.
No history of smoking.
Yeah, which is same for Curie, I think.
And then it's high grade, lipidic spread, no stromal invasion. Well differentiated. So
they also, yeah, they also give us like genetic mutation information.
Negative.
This was sequential transplant.
I actually didn't look at that much in detail, but yeah, let me figure that out. Yeah.
Oh, so pulmonary function test is what they would look for too. So you have to have that in your
manuscript as well. Yeah.
report. So this is JTOCRR, okay.
Yeah, JTOCRR.
Was that JTOCRR you asked, or was it just JTO?
I think it was JTO, just JTO.
Okay.
Just can I ask just one last question? So for the case presentation part, because of my bad, I wrote it again, and Junie helped me a lot to reduce and organize everything again, like coherently. But what I found was Isel already wrote abstract, right? And she told, so the way I wrote it was just chronically. I just described Curie's case in a chronicle way. But Isel gave me an advice that maybe this is because for him, the most important period was transplantation. Maybe you made all the things before done in transplantation in a very succinct way, and then more focusing on the transplantation and then surgical point of view. So do you think that would be better way for case presentation part? So
it all depends on the word limit.
Word limit.
You don't have word limit. You can go over the whole history chronologically. But obviously the history of how he get to the transplant eval is not as important as what happened during and after transplant.
Okay.
I would say I would focus on him responding to lenvatinib, because that's how he was able to stay alive during the evaluation for transplant. But other than that, how he failed all the other therapies can be very short.
Okay, I think
You don't have to go through how many cycles he received and next scan was showed. That's not the whole point of our case. Our point is, how did he make to the transplant? Right?
And what happened after that? Okay.
Yeah.
Okay, gotcha.
So here, what the lesson from this paper is that even though the first recurrence happened, what, 15 months,
Yeah, 17.
17 months, he was able to stay alive for how long? 13 years?
10 years. Yeah.
13 years, and only stage 4 recurrence, which is multifocal recurrence, happened at what, year 10? What was the year?
Over 10 years, 139 months, basically
What is that?
11 years. Yeah.
Is it 11 years?
Mhm.
Okay. So it's amazing that without transplant, he could have died.
Within a year, I think. Maybe.
Yeah, because there was probably no therapy that was working for him. So I think this is a great case. Curie might, Curie has MRD positive disease by Gardent. So if you look at Japan Circulate data, or well, just like the lung cancer Signatera data, the likelihood of him having radiographic recurrence is
Pretty high.
yeah, how high? I mean, if you
Oh,
within a year, he will probably have more than 60-70%. He's going to have recurrence. But does that determine how long he's going to live? No. It might be a single nodule and we can treat with SBRT. The next nodule can pop up in 10 more years later. Do you understand?
right. He got pneumonectomy for his first and second recurrence. Yeah.
So yeah, lots of thoughts
Lots of-
generated from this paper. So this is really good. Really good. Yeah, that's why. Well, I don't know how they did it, this double lung, but and I like their title, local salvage. How local salvage has really extended his survival. I mean, we're just 6 months out, so we're not there, but I think it's still worth reporting it with our molecular data.
True. I hope Curie did do more better than this patient, but yeah, let's see. We'll see.
See, it's a sad feeling because like Vivian Panu, we know her molecular disease is on the rise. We know for Curie, his MRD is positive by Garden. But I think this is the nuance we're gonna do. Like the tissue-based MRD assay was persistently negative. We're gonna write that in our we're gonna emphasize that, and we're gonna just write about Garden in one section of the case discussion, and maybe mention that in the discussion later on, as different MRD assays show different things, and because at least one is positive, there is still a high risk that he will have radiographic relapse. However, then describe Circulate Japan and all immune surveillance and all that, and then all throughout it hasn't been going up. That the level's been stable. That means there's some sort of immune editing process ongoing, checking, making it stable. Otherwise, it's going to keep going up. That's the nature of cancer. It's gonna grow. But we didn't see that. It's stable. So in that case, in that way, maybe it's not clearing up because of the chronic immune suppression he has to be under. So we can talk about it. It's just it's a fun fact. I mean, for us, for discussion, not for him. But
yeah.
Anyway, I think.
Yeah, that's all
great.
for me, I think. Yeah, thank you.
Anything else?
Yeah.
No?
Yeah, no, that's all. Thank you.
Okay. So after the lab meeting, Liam and you both of you can discuss the actual MRD protocol we're gonna send to companies. Okay.
Okay.
All right. For the lab meeting, we'll wrap up here. It was really good discussion. And we'll reconvene next week.
Thank you.
Yeah.